Yes.
Recording will be starting in 3, 2, 1. Please start, sir.
Yeah. Good morning, everyone. Today, again on second Sunday of the month of November, almost after all the festivals, we are meeting again for FOGSI ICOG PG Clinic, another PG program for PG education and PG teachings. We are following all the NMC guidelines, and accordingly, we have revised our program also, and we have including competency based learning as well, and skill based learning program, and we are also simulating hands on in terms of doll and dummy and pelvis for our obstetrics and gynecological students. So this month we are having with us all the learned faculties and our chairman of the ICOG, who will be next year, will be taking over as a chairman, Dr. Parag Beniwale. So before I start, I would like to express my sincere thanks and gratitude to FOGSI President, Dr. Jaideep Tank, FOGSI ICOG Chairperson, Dr. Parul Kodawala, ICOG Vice Chair, Dr. Sheila Mane, Secretary, Dr. Sarita Bhale Rao, for allowing us to continue with this PG program every month. And we all are happy to share that we have crossed 3 years of this learning program, and now we are in the 4th year. And we are hopeful that under the dynamic leadership of Dr. Parag Beniwala, we will continue with this program in the next year also, in 2025. And do hope that under the dynamic leadership of Sheila Mane also, we will continue with this program. So a long journey for all of us, and we are foreseeing a long journey ahead of us also. So let's see how far we can go ahead, and we will continue with this program. It is a very popular program among PGs, and every second Sunday at 11:30 a.m. we all meet together and try to do some justice to this program and try to spread the knowledge and awareness and give some learning points to the students. So along with me, Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman always contribute to this journey, and I am also grateful to them also to be a part of this. And day by day, we are trying to improve the program, and we try to give some new information to the students. So before I start, I would like to invite our chair-elect, Dr. Parag Beniwala, to say a few words.
Thank you, Ashok. I bring greetings from ICOG, and it's a pleasure to address everyone in yet another episode of PG Clinics. And I must appreciate the efforts put in by the 3 conveners, Dr. Ashok Kumar, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman, who have worked on this project tirelessly for 3 years and 1 year more for sure. And I'm sure Dr. Sheila Mane will also continue. So this educational activity of ICOG, which is so popular among students, will continue. I must thank all the teachers who are contributing to the educational program today, Dr. Haresh Doshi, Dr. Kiran Pandey, Dr. Ashish Mukhopadhyay, Dr. Nitin Raithatha, and Dr. Ajit Nagarsekar. I don't see Ajit joined, but then I'm sure it's going to be a great learning experience for the students as well as all the viewers. Special word of appreciation to Dr. Shweta Jain, who's the teacher coordinator from PGIMS Rohtak, for helping us to conduct this program. My best wishes for the program and happy learning to everyone. Thank you. Hafizur, you can take over.
Yeah. Thank you so much, sir. Ashok sir, are you there? I think sir is having.
So I think let's go ahead. Yeah.
Okay, sir. Thank you so much, sir. Parag sir, you have always been the source of encouragement, I think, along with our previous chairpersons also. So we hope to continue this program, as you said, and Ashish sir, just to have a few words because you have been a great support, especially at many times. Ashish sir.
Yes, good morning, everyone, and my respectful regards to all the luminaries and the people in chair in FOGSI and ICOG. Dr. Ashok Kumar has already named them and thanked them enough. I think that the key word in this ICOG program is continuous improvement. People who have seen our initial programs will understand, appreciate a major difference in the format of the program, which Dr. Ashok Kumar has said, it is as per the NMC norms. And as NMC norms keep changing, we also try to change ourselves and improve ourselves. And also, one another thing that I have noticed is the improvement in the art of presentation of cases by the students. Over the years, I've been observing that. I have been traveling all over the country, and I'm seeing this. This is a good sign. I do not take the full credit to the ICOG or maybe the teachers, but it's actually the, I think, improvement in the teaching materials which they get upon, and also the continuous CMEs that the FOGSI and ICOG they're doing all over the country. Not only because of this program, but also many other programs. Our committees are very, very active these days. Committee chairpersons are working wonderfully. The vice president is also equally active. And our dynamic president, Dr. Jaideep Tank, is always encouraging about these programs. So I think that all in all, we are on a good line and good path. And we always expect the collaboration and support from all the teachers all over the country. And their thoughtful contribution to this program is always welcome. We have always welcomed them. And last but not the least, students who are not being able to see this program today because of the coming exam they have. I think even the exam going students will be benefited by this program today. But even then, if they cannot see that, it's all there in the ICOG website. And kindly go back to the ICOG website and let us all teachers encourage the students to go to the website and visit this program. I wish a very happy New Year to all of you. Thank you so much. Let us begin.
Thank you so much.
Thank you, Dr. Ashish.
Yes, sir.
Thank you, Dr. Ashish. So before we start, we welcome our faculty today, Dr. Haresh Doshi, Professor of and HOD of GCS Medical College, Ahmedabad. And we all know him, and he is our faculty for a long time with us. Today, he will be demonstrating breech presentation and mechanism labor and assisted vaginal breech delivery. So we will learn from him all the tricks and tips for delivering a breech, how we should learn this art of breech vaginal delivery. Then we have case discussion this time on polycystic ovarian syndrome, and we want to handle the situation in adolescent. We have earlier tackled the situation in reproductive age group and different times. Now this time we are talking of adolescent PCOS, and we have again eminent teacher with us, Dr. Kiran Pandey. She is a former HOD of GSVM Medical College, Kanpur, and Dr. Nitin Rai, professor, sorry if I'm pronouncing it wrong, professor of Medical College from Anand, Gujarat, and Dr. Ajit Nagarsekar, Associate Professor of Goa Medical College. And in the end, to learn the technique, to understand the skill, which is an important component nowadays in the curriculum, operative vaginal delivery by forceps. So forceps, art of forceps application and how to deliver with the use of forceps will be demonstrated by Dr. Ashish Mukhopadhyay, another teacher from Calcutta, and he's again we have a long association with him, and he has been regularly featuring in this PG program every month. And just to remind you all that all these recordings are available on the ICOG website, so you can take the advantage of visiting the ICOG website and see the previous program where many information and knowledge has been shared by all our eminent teachers and the students. And today we have students from PGI Medical College, Rohtak, And Dr. Shweta Jain, professor of PGIMS Rohtak, is the coordinator, and she has guided her students, Dr. Vaishali Gautam and Dr. Prerna Verma, to present this case on adolescent PCS. So I welcome you all, and all the students who are there in the audience who have logged in today on this Sunday. And we hope that it will be very fruitful and useful program where we all can have a very good learning and understanding of the subject. So thank you very much, and over to Hafiz to start the program.
Yeah. Thank you so much, Ashok sir. As you sir said, that is the program is in recording for 3 years. The student can go to the website and access this. Along with this, sir, we have thought that we would like to have feedback of the students after this program, as well as the faculties, those who have participated, whether they have any suggestions. We will share a form through their links so that they can suggest any particular topic or they want to have, especially the students, as well as there's some any improving measures from maybe from our faculties. So we would like to do that. So I would like to request Harish Doshi sir, as sir is professor and HOD at the GCS Medical
okay. Already
College.
introduced. Don't waste time. Yeah.
Yes, sir. Please, sir. Please share your screen and sir
Yes.
start.
Share the screen. Yes. Okay. Okay. Happening? It is coming?
No, it is not coming.
Yes, sir. The Zoom screen has come. Can you share your PPT, sir?
No, PPT तो नहीं है ना मेरे पास. मेरे तो
Okay.
No, he
Pelvis
doesn't
ही है
have
ना.
that. I think he go for the direct presentation. There is no need to share screen.
हाँ. So
Sir,
that
if
is.
you're not having PPT, then you don't have to share anything. Yes, sir. Yeah,
Yes,
perfect,
yes.
sir. Yes, sir.
So now the full screen. Technical person.
Technical person, can you
Spotlight.
ping up?
Spotlight.
Yeah.
Spotlight, yes.
So that spotlight, yes.
Okay.
Perfect. You're okay?
Okay.
Yeah, sir.
Oh, very good morning to all. I must thank the FOGSI office bearers, Dr. Jaideep and Dr. Madhuri, and ICOG office bearers, Dr. Parul, Dr. Sheila Mane, and Dr. Sarita, and incoming chairperson, Dr. Parag, and the 3 great coordinators, that is Ashok Kumar, Ashish, and Hafizur, for successfully conducting this program last 3 years, as well as inviting me for this short presentation on breech, mechanism of labor, and conduct of assisted vaginal breech delivery. Why you want to? Nowadays, people are doing cesarean section for all breech, not only primary breech. Why? You must learn. Naturally, first for the exam, it is in your curriculum, you must learn. Second thing, there are some situations where you are indulge in conducting the delivery. Patient comes late in labor, that you have no choice, breach on perineum, or patient refuses for cesarean section, second gravida, third gravida, everybody says you should conduct delivery. At cesarean section, some of the steps are same, as breech delivery, and second baby or twins. These are the situation where breech delivery is to be conducted by a obstetrician. And that's why you must learn it. Coming to the first part, that is the mechanism of labor. As you know, like Vertex, there are 4 presentation in this breech, LSA, RSA, RSP, and LSP, left sacroanterior, right sacroanterior, right sacroposterior, and left sacroposterior. Naturally, like Vertex, anterior positions are common. Left sacroanterior, we will do first the left sacroanterior, that is the diameter of engagement, is left oblique. In Vertex, it is opposite. If it is occipital anterior, it is right, left occipital anterior is right oblique. Here, because of the 2 buttocks, in left sacroanterior, it is the left oblique, from left sacroiliac joint to right iliopectilaminus. So that is the diameter of engagement. Engaging diameter is of the fetus, that is bitrochanteric, 10 centimeter. So first the mechanism for buttocks, the buttocks engages in the left oblique diameter, then descent occurs, like in vertex, descent occurs. That is, here it is in vertex, it is flexion. Here it is called compaction. The all buttocks are crowded. Then at the pelvic floor, internal rotation occurs of 1/8 of a circle. Then anything which is there on the sacral, right, lower down, is pushed downward and forward. So ideally, theoretically, the posterior buttock should deliver first. But what happens for that to happen? That should be some movement at the sacrum. And sacrum is no intersacral vertebrae movements is allowed. So actually in real life situation, the anterior buttock is seen first and almost delivered. And then by lateral flexion, posterior buttocks delivers. Then what happens? Then at the same time, when the buttocks are coming out, shoulder engages in the same oblique diameter. That is the left oblique diameter. Again, descent occurs, internal rotation of a 1/8 of a circle. And also now the posterior shoulder delivers first. Again, I'm telling you that in real life situation, because anterior things are visible, we want to deliver that anterior shoulder first. But if you are not delivering, everything which is posterior will come out by right anterior movement. That is in a vertex presentation. It is, you see, it is a head delivers by flexion. Anterior, in a momentum phase, it is coming anterior, that is flexion. This is extension. So here also, anything from the fetal part which is posterior in the sacral hollow will be pushed forward and will deliver first. But because in sacroiliac joint, there is no movement, the anterior buttock is also born, and at the delivery, we see anterior shoulder, so we flip out and deliver the anterior shoulder. Theoretically, posterior structure should come first. That is the mechanism of labor. Now the head. Head, as you see, head anteroposterior diameter is 90 degree, to both the shoulder and buttocks. So head engages in the right oblique diameter for LSA, right oblique diameter. For LSA, right oblique diameter, and I can put this like this, and the engaging, because there is no good flexion, it is suboccipitofrontal, 10 centimeter, right? Like bitrochanteric was 12 centimeter, and then shoulder, right? Bitrochanteric was 10 centimeter, and shoulder was 12 centimeter. So here also it is 10, not like 9.4 of vertex presentation. Remember that. So again, I'm repeating, the breech LSA engages in the left oblique diameter, bitrochanteric 10 centimeter, descent with compaction. There is, right, internal rotation of a 1/8 of a circle. Ideally, posterior buttock should deliver first, but because less movement allowed at sacrum, anterior may deliver first. By lateral flexion, the rest of the baby delivers. Then shoulder engages in the same left oblique diameter, again internal rotation of the shoulders, and then delivery by lateral flexion. Head engages in the right oblique diameter, it is less flexed head, so it is suboccipitofrontal, 10 centimeter. Descent occurs, somewhat flexion occurs. Now that is the flexion is done by only uterine contraction or your fundal pressure. There is no pelvic floor in a like vertex, but the flexion is completed by lever mechanism. Here, less flexion completes. Head rotates in a 1/8 circle at the pelvic floor, and the head delivers by, right, gradually flexion, because everything comes from posterior to anterior. I am repeatedly telling you. So that what happens is chin, face, forehead, bregma, and occiput. So this breech delivery happens this way, right? From the, I can hold it like this, and then, right, you can have this. So fine. So that is flexion. Head has come in a breech, and then with flexion of the subsequent, right, parts, the complete baby delivers. Now coming to the sacroposterior breech. Sacroposterior breech. Suppose it is right sacroposterior. Right, this is anterior supposed to be, so right sacroposterior. Because there are two buttocks, in occipitoposterior, the head has to rotate 3/8 of a circle. But here there are two buttocks. So one buttock is already there in the anterior quadrant of the pelvis. So again, when the descent occurs, only 1/8 of a circle is required for buttock to come in the midline behind the symphysis pubis, because there are two buttocks, not like occiput one. So 1/8 of a circle, same thing mechanism for buttocks and shoulders. When the head comes, it has to rotate 3/8 of a circle. Eighth of a circle, it might have rotated by the mechanism of shoulder or buttocks, but at least 90 degree or 3/8 of a circle, because it is for sacroposterior, it is right. For sacroposterior, it is like 3/8 of a circle, 3/8 of a circle. So that happens right with this, that the head engages in the right opposite oblique diameter, because it is now breech posterior. Breech anterior, same oblique diameter. Breech posterior, opposite oblique diameter. If it is a vertex anterior, opposite diameter of engagement. If it is vertex posterior, same. You can understand this, right? So that is right, engages in the same diameter, I mean the opposite oblique diameter, then descend with lateral flexion, delivers one by one internal rotation and lateral flexion. First the buttocks, and then the right, and then the shoulders. But the head must have rotated 1/8 of a circle by this mechanism of this buttocks and shoulder rotation, internal rotation. Here there is, right? Now head has to rotate 90 degree to come out, right? So that is sacroposterior, which is a problem thing. And that's why in conduct of delivery, we always teach that you must keep the back anterior, because like occipitoposterior is in a vertex is a problem, in after coming head also is a problem. Okay, so mechanism of labor is over. From left sacroanterior, right sacroanterior, same, but sacroposterior, other things are same, but the head has to rotate. And as compared to vertex, the flex head is not there. So if it is a no flex head, after coming head is as such a problem. And if it is a occipital like sacroposterior, it's a more problem. Coming to the conduct of breech delivery, assisted breech delivery, right? So for 3 types of vaginal delivery is there, right? The assisted breech delivery, spontaneous breech delivery, and breech extraction. Simply dividing is, you assist something at some point, usually at the umbilicus level, you start assisting, helping. That is assisted breech delivery. We will have the details. Spontaneous breech delivery happens naturally, spontaneously, complete, no help is done. It nowadays in real life, it is happening in absence of doctors or absence of trained nurse or midwife. When you are there, you always do assisted breech delivery. Don't allow that. But if you're not there and patient is delivering on her own, then there is a spontaneous breech delivery. Breech extraction. Here, as compared to assisted breech delivery, from the beginning, the right extraction is done, pulling the whole baby is delivered out because of some emergency indication. Cord prolapse, fetal distress, even sometimes maternal distress, right? After internal podalic version, patient is under anesthesia, second baby of twins delivery, right? Sometimes bleeding has started excessive. So you are in a hurry. So don't wait for mechanism to happen and do extraction, pulling, catching the legs from the beginning to end. That is breech extraction. So breech extraction is only limited to some special indication. Spontaneous breech delivery is not allowed. Assisted breech delivery is done. And for vaginal breech delivery, right, there are some prerequisites. It is not right, maybe may or may not be given in the books, but primary breech nowadays we don't go for vaginal delivery. We have done in our types, but nowadays in current medical legal era and scenario and science, we don't, we second, third gravida. So type of breech, it should be frank or footling breech presentation. Other standard prerequisite should be there, that the doctor or nurse should be trained in breech delivery. At least if he is a junior or right novice, then some senior person should be standing nearby. Breech delivery should not be left to the experienced person. Okay, so even in a medical college, 3rd year, 4th year, SR mate should be there. Fine. Then neonatologist must be present. Anesthetist must be present. right? Patient consent, because you have to explain that as compared to cesarean section, there is little risk to the baby in a vaginal delivery, and then consent of the patient, because the advantages of vaginal delivery are many more than, many than compared to cesarean section, at least from maternal point of view. So that's why you have to explain that for mother, delivery is good. For baby, cesarean section has some age over vaginal delivery, which can, if patient does not cooperate, you cannot deliver the parts in time, there may be some morbidity, rarely mortality. So that consent of the patient for vaginal delivery is to be taken, right? Neonatologists, anesthetists, breech criteria, baby should not be overweight, more than 3.5 kg. No footling presentation, complete breech or a frank breech presentation, right? Then, okay, all this patient, no other indication of cesarean section, obviously. Parity of the patient, I told you. So pelvis must be adequate, roomy pelvis, better, right? So then you subject this patient for vaginal breech delivery, which is assisted breech delivery. 3 basic principles we teach from undergraduate days, right? Navel pull from below, let it get pushed from above. Because when you pull from below, the arms also get extended and head also get extended, which is a larger diameter and a problem. So better let it, right, get pushed from above or help that push, but don't pull from below. Slow, controlled delivery. Don't be in rush. Don't be in hurry, right? That creates more problems than slow, controlled delivery. And from the buttocks onwards, when you are the umbilicus is being delivered, try to keep the back anterior. Try to keep the back anterior. When the baby comes out, then try to keep the back. If it is lateral or posterior, rotate it that time. That is easy. So that means make the occiput anterior for the head. Occiput bring after coming head, it will be easy. So 3 principles again. Never, right, pull from below, let it get pushed from above. Slow, controlled delivery, no hurry. And third is keep always the back anterior. Okay. Now coming to the actual management of first stage of labor, right? Okay. First stage of labor. Patient is better kept in the bed rest, right? If it's ambulatory is okay, but there are more in any malpresentation. This happens that the patient is walking and ambulatory. There are more chances of early rupture of membranes in first stage of labor, right? So that should be as long as prevented. You may require anesthesia. So keep either kneel by mouth or only liquids orally. Better kneel by mouth. Anytime something happens, cord prolapse occurs, and you may have to go for cesarean section. So that is right, always to be there. Then ideally, electronic fetal monitoring, but not must. You can monitor by your Doppler ultrasound or by stethoscope, even, right? Then epidural analgesia, best. If the facility is available, if the patient gives consent, because you may require some manipulation. By chance, you require to go for cesarean section in between, then you can easily resort to same under epidural analgesia. The cesarean section can be done. So that is right, always to be done. Membrane still may rupture, even if the patient is lying down, because buttocks is not a good fitting part like vertex. So membranes may rupture early, 4, 5, 6 centimeters. Immediately do PV. Immediately do PV to rule out the cord prolapse, right? To rule out the cord prolapse. So bed rest, right? Liquids only or kneel by mouth. Inform anesthetist and neonatologist, right? Then nothing is to be done. Just watch FHS every 15 minutes standard, right? Either by electronic fetal monitoring, then it is continuous, maybe there. Otherwise, intermittent based, no problem. Epidural analgesia you can give. Oxytocin is not required normally. Individual case, exceptional case, if the contractions are not good and all other factors are there. Second gravida patient, first vaginal delivery, pelvis roomy, baby average, fetal breech is a footling or complete. You are still thinking that vaginal delivery will happen, then only to augment the right power, that is oxytocin. But it is a controversial. And induction of labor, again controversial. Normally we do nowadays all breech, we do cesarean section only, right? Even second gravida people are not giving trial. But, right, induction is also not favored, right? Controversial. Oxytocin, induction, forget. Normal breech delivery, first stage, again I'm repeating, you have to do all these things, keeping the patient, right, in bed, in vertex, we allow the patient to ambulatory. That helps in a progress of labor. Here we don't want, because it may lead to rupture of membranes. Then if rupture membranes still occurs, then you do immediate PV to rule out cord prolapse. Then kneel by mouth for anesthetic, right? Preference, anesthetic point of view. Then electronic fetal monitoring, best. Fetal ultrasound can be auscultated. Epidural analgesia, okay, fine. So these are all the first stage of labor. Wait, nothing is to be done. First stage, no intervention. Second stage, patient is now second stage of labor. In that second stage of labor, bring the patient to edge of the table. Lithotomy position, always lithotomy position, right? Let the buttocks stretch the perineum, like in a crowning of head in a vertex presentation. Let the buttocks, my teacher used to tell me, let the buttocks tear the perineum. That much stretching of the soft tissue will help you in the subsequent parts of the fetus to deliver easily, particularly the head. So that's why give late episiotomy, right? Give generous episiotomy. Good size. Soft tissue should not come in your way. Pelvis you cannot change. So soft tissue should be cut adequate, generous, mid. And episiotomy, it is said, the question is undergraduate asked, why episiotomy is given in breech? So answer is, say, people say, it is for after coming head of breech. Okay, it is for after coming head of breech, but it is for after coming head of breech, but it is, you may require some manipulation. You may require some manipulation from the beginning for the buttocks part or shoulders, right? And delivery of the right arms. So that will be facilitated by good size episiotomy. So episiotomy helps in many ways, and then episiotomy should be given from the beginning and not when the baby is delivered and after coming head is remaining. Okay, so that part is to be done. Episiotomy is to be given, and then nothing is to be done when the baby, now first the buttocks, the posterior buttock, right? As I told you in the mechanism, normally should be delivered first. But when we see the anterior buttock, and then if it is frank breech, extended legs, you can pass your fingers. You can pass your fingers, go to the knee, flex the knee, and then, right, abduct the leg so that the foot will come, it will flex down. So pressing the popliteal fossa or knee, the one anterior leg should be brought down. Same way posteriorly. Or you can wait, good episiotomy, baby delivers up to umbilicus, and then when the beyond the knee part is there, you can deliver it out, right? So that is there. Once you are delivering like this breech, this is, I will show you here. This is some. So when it is seen, right, it is seen, but I hope you will see. Yes. So this, when it is this is the right hip joint. You can pass your fingers when it is being delivered, right? It is being delivered. So this you can, this the 180 posterior leg is delivered by this soft baby. That's why. But you pass your right finger, two fingers anterior to the thigh and press the knee. So press the popliteal fossa and the leg will flex, and then you can catch the leg and bring out that. Right, you can catch the leg and bring out that. So that's how I'm showing this. Right, okay. Yes, for you. So this, I have to pass my finger to the anterior part of the leg and push it to the popliteal fossa. Right, I'm going for this way. Okay, this baby is coming out. I'm sorry. Right, we will have that one thing. Slightly bulky baby. I should have done cesarean section rather than delivery. Okay, so both limbs are flexed, and then the anterior limb is born. Okay, so once the one leg is born, second leg is to be pulled out, right? Okay, so that is the first leg, and the second limb is come out. Now, during exact conduct of second stage, ask the patient only to push during pains. And at that same time, you can give the fundal pressure to keep the head flexed and assisting delivering or downward push. That is also called crystallar maneuver. Not exactly, but that keeping the fundus, pressure over the fundus on the mother's abdomen, that is flexing the head and pushing the baby down. So I told you the principle. Don't pull. Let it get pushed from above. Okay. So that is there, though that happens. Then once both the limbs are born, lower limbs are born, then this half of the baby is out. Okay. Half of the baby is out. Here for this way. Right. I'm sorry. Okay. So now this is the symphysis pubis, right? Right hip bone, left hip bone. And then, okay, I should have done that way. It is a breach. Fine. Now, at this level you enter. Once the umbilicus is born, lower limbs are delivered, then only you enter. That is, cover the baby with the dry, warm towel. That helps in two ways. Your gloves and everything is sticky and right, the vernix and all that. The baby do not slip from your hand. One. And second, dry, warm towel will, suppose it's a air-conditioned labor room. So difference in temperature will not happen. If that happens, in temperature and that happens, that will lead to what? Right, that will lead to stimulation of premature respiration. Okay, premature respiration. So that you don't want. So that's why I cover the baby with a dry towel. I should have if not towel, I can show you my handkerchief. So that is there. All right. So, okay. So this way, right. Now, palpate the umbilical cord. Normally, you will feel the pulsation. If you don't feel, don't be panic, because the cord may be compressed here at the inlet. The cord is going from umbilicus to the placenta. So cord may be compressed there, and that's why sometimes if it is not seen, you can auscultate from abdomen, or you can use the monitor, the sonography probe. Here, put at the suprapubic region the patient. You will see the good, nice contracting heart. So every time pulsation not seen means not dead baby. And why should baby die in 5-10 minutes, right? When you have already conducted the first stage of labor and monitored the patient. So that does not happen. So don't be panic when you count, don't palpate the pulsation in umbilical cord. Be alert, but it does not totally mean or automatically mean dead baby. That is very important. And second thing, pull the cord. Again, that also people say that you pull because the rest of the baby when delivers, the cord should not be stretched. But that is also, if it is possible, do it. Otherwise, it's a stretchable, compressible thing. And then in practice, theory, you must tell that palpate the pulsation, bring the cord down, right? Cover the baby with towel, and then wait for the contraction to come. So this is okay this is okay for theory. In practice, don't be panic. Panic is never to be there. Should not be there. Now, with pelvic femoral grip, don't catch the soft tissue. That is the abdominal part of the baby. So always the pelvic grip, pelvis is to be held with the towel. And when the pain comes, ask the patient to push, right? You may have some fundal pressure here, but otherwise, first stage you have given that, right? Now, actually, the shoulders are first to be delivered, and then the head. Lower limbs are delivered, up to umbilicus is delivered. You can note the time. Some people say note the time, but the time noting is always a stressful thing, right? In after coming head, you have to think of time. That is important, but don't from at this level, right? Then when the baby is still delivered, right? see for the medial border of the scapula. If they are extended hands of the baby, like extended head of the baby, hands of the baby, then the winging of scapula occurs, winging. So then you can be careful. Then there are two methods, either lobset or classical. Classical we don't do nowadays. Lobset we are doing. Lobset we are doing. I use lobset method for flex hand, flex upper limbs also. Flex, it is flex tail also, but it is good for at least extended arms. So for normal flex hands, you have to have just simple flip out or lobset. For extended arms, either you have lobset or classical method. Classical method requires anesthesia. So we always do lobset, which works in both flex hand or extended hands. Now, what is that lobset? That I will tell you. Before that, only when the inferior angle of scapula is seen, then and then you do start lobset maneuver. And there is a winging of the scapula. You keep in your mind, note that there may be extended arms. So what is to be done? Because of obliquity of the pelvic beam, I will show the first lobset here. That is, right, the one arm is seen. Now I have to hold the baby with the two hands and pull the baby and rotate it. So, I'm sorry, rotate it. So the posterior shoulder becomes anterior. And not only it becomes anterior, it has come down also. So I can flip, I can pass my fingers and deliver. Why this happens, Law said, he used this procedure for the what person, I'm sorry, that in the pelvis, the obliquity of the pelvic beam, obliquity, the obliquity of the inlet, right? The obliquity is almost 55 degree with the horizontal, 55 degree, right? 55 degree. If I show here, you have to keep the baby pelvis like this. And this is the obliquity normal in a standing position, oblique. Meaning that the symphysis pubis is lower down. Sacral promontory is higher up. When baby is straight, the anterior shoulder may be above the symphysis pubis, but the posterior shoulder is inside the symphysis pubis. So when you pull the baby here and rotate it, the posterior shoulder which comes anterior and becomes anterior shoulder always either below the symphysis pubis or just behind the symphysis pubis. When you started that lobset, the anterior shoulder which was originally anterior was above the symphysis pubis, but posterior shoulder is because of the same level. This is say my anterior shoulder, it is above symphysis pubis, but the posterior shoulder is, you can see, it is inside the sacral. When I rotate it, it becomes like this. The posterior which becomes, it rotates in a pelvis, right, in the hollow. And then, so when you rotate and give traction, it automatically brings, right, when you rotate, right, it was like this, right, like this. Then I rotate it, it becomes like this. So it comes down behind the or below the symphysis pubis, and very easy to flip it out. And then you can lift the baby, and deliver the posterior arm as such, or you can reverse the whole lobset again, which was posterior and now become posterior. You can bring it. So lobset maneuver you must practice. You must know the principle of lobset is the lower obliquity of the pelvic beam. The posterior margin is higher up than the anterior margin, symphysis pubis. So when the baby is in the pelvis, baby is being delivered, breech presentation, the anterior shoulder may be above symphysis pubis, or posterior shoulder is always inside the pelvis, that is below the sacral promontory. When you rotate it 90 degree, so not 180 degree, so it becomes posterior to anterior, and then it automatically comes down. You can reverse for the second arm, or you can just pass the hand in the posterior, which was anterior, now it is gone inside. You can deliver it out. Fine. So lobset. The classical method I should not mention. It is right with anesthesia, and then it is what with anesthesia, but it is say like this. Okay. In that, you have to go your hand inside under anesthesia, go beyond the arms, right? Go beyond, I'm sorry, I should, so like this, right? And then go catch the hand, flex it on the fetal face side, and flexion it on the flex side, baby is moving without my much movement, and then bring it down, right? So it is, I can show you. It is like this, right? Suppose this is my baby's arm. I pass from the back side, go beyond this, and then this. Flexion and towards side. And this arm is being down. Second arm also can be being down like this. This is for extended arms. Classical method, under anesthesia. Because you have to pass higher up in the uterus. So that is classical method. Normally, Lancet method, 180 degree from posterior to anterior, the automatically shoulder, which is posterior, now becomes anterior, comes out or at the below the symphysis pubis. So that is for arms, right? Now both the shoulders are delivered. Now the main thing comes. For this reason, the people are not taking chances and doing cesarean section. So after coming head is right. You can take 6-8 minutes or up to 10 minutes. The people give different time limits. But I have used 7, 8, 10 minutes when particularly I am doing forceps, right? So nothing happens. But more than 10 minutes, definitely especially happens. This is a wrong impression in a breech delivery by the doctors. That 5 minutes is a big time. 5 minutes means 300 seconds. You should not be in a hurry. When you pull the head and deliver it fast, sudden compression and sudden decompression inside leads to tear of tentorium cerebelli and intracranial hemorrhage. And baby dies of that hemorrhage and not because of asphyxia. Okay, you could not deliver the head and then there is asphyxia. No. More babies by postmortem, it is proved, have died because of ICH and not asphyxia. Okay, so have this in mind always. And this usual story, what happens? I'm conducting a breech delivery. After coming here, there was a difficulty. And then the baby came out, did not cry, or maybe severe birth asphyxia, or HIN grade, or maybe died. And that impression comes in my mind. And next time I become more panicky and pull it fast. That is the wrong thing. You are in a wrong track because that was not the cause. Asphyxia, ICH was the cause. And this time, second time, you are doing more ICH by pulling it fast. No, right? Forceps is the best because forceps is not done nowadays. After coming here, who will do? I am doing it, but otherwise people are not doing it. So forceps is the best, but otherwise. So after coming here, the first principle is let the baby hang. Let the baby hang. Right, shoulder I delivered. I will deliver the second shoulder. Okay, right. Unsupported. That is by gravity, the next contraction, at least 1 minute, don't do anything. At least 1 minute for after coming in, don't do anything. Let the baby hang. I have a nice video of whole breech delivery, but it is at 15 minutes long, so I do not include in this presentation. Otherwise, it is a live breech with forceps delivery for after coming in. That I will show you sometime. But otherwise, these steps are important. That nothing is to be done. And what is to be done? That is right. When suboccipital hairline is seen, then only do any maneuver to deliver the after coming head. There are three main maneuvers. There are many, but there are three main maneuvers we practice, right? But for that, you must see that the suboccipital, so head is engaged. It means the top of the head is not higher up, right? It is there when suboccipital hairline is seen. So always have this in mind. Suboccipital hairline of the baby should be seen. Then and then you do maneuver. Otherwise, when the baby is here and you, whatever way you do deliver, baby will extend on its back and not. You want the head to flex and come out with your whatever maneuver. Okay. So first maneuver, which was initially practiced more, right? I will deliver it this way. Was suppose this is pelvis here, right? Okay. So Brown's Marshall method. You catch the lower limbs. By between one finger to prevent chafing, 2 legs. Give extension. Suppose I'm conducting the delivery, right? And in a wide arc of a circle, you rotate so that the sympathetic pubis keeps the head flex, and also suprapubic pressure is to be given by the assistant, suprapubic pressure. So Burns-Marshall method. But here the traction is not that great, and that's why Burns-Marshall initially practiced in some of the European countries. Nowadays they have stopped it, right? So Burns-Marshall, let it hang for 1 minute or 2 minutes to see the occipital hairline, pull it, and rotate in a wide arc of circle. The symphysis pubis, which is here, will keep the baby flex and head will come out. Second, jaw flexion and shoulder traction, Mauritius-Smelly-Witt technique, MSV technique. All three different great obstetricians from 3 different countries, right? Mauritius, Smelly, and Witt. Vietnam, Smelly from some European country, and Mauritius from, right, Germany, if I'm not wrong. So that MSV technique, Smelly is from England, UK. So this MSV technique is good that, right, on the left forearm, suppose I'm right-handed, the baby's one leg is here, one leg is here, one arm is here, one arm is here, and my 2 fingers are keeping. We used to previously teach by keeping the fingers in the mouth. It is good for a good grip, but that can lead to temporomandibular joint damage to the injury to the baby. So keeping the 2 malar prominences, it is not good grip, but still it works. Then right hand on thumb and index finger on one shoulder, and little finger and ring finger on other shoulder, and middle finger extended to keep the baby head flexed. Again, first, the hanging of the baby for 1 minute, suboccipital hairline is seen, then assistant giving suprapubic pressure, and this, right, splinting the baby between 2 arms and keeping it flexed, and then give traction downward and gradually forward, right? It was big arc of a circle only by catching the foot. That was Burns-Marshall. Traction from away, and it does not give good traction. This is giving good, you have to, baby, hold your grip, right? Totally, right? So that is MSV technique. MSV technique is now most commonly practiced and successful also. You have to right, at least once or that tries. And when any vertex delivery baby delivers, no, when baby normal cries, then baby is clean and all that. Have this baby in your hand and check it, how much grip you can have. So that helps you in actual when you are conducting breech delivery. So practice not practice means you have how because in hurry, tension, in real conduct of delivery, people are not doing ऐसे करते हैं, आगे से हाथ जाता है, पीछे से नहीं, 1 leg on this side, 1 leg on this side, one and arm on my left arm, and then this and this, and then first downward and gradually, and suprapubic pressure by assistant. Third is the forceps. Forceps is the best because it directly catching. Say, Burns-Marshall, you are pulling from here. Jaw flexion, shoulder traction, right? And Burns-Marshall flexion is not much maintained because you are extending from the beginning. In jaw flexion, shoulder traction, you are flexing somewhat as compared to Burns-Marshall, but again you are giving traction to the spinal column. Here in forceps, the blades goes like this. I have not brought the forceps, but keeping the baby right anteriorly, you can have the normal type of forceps. I have done few, not many, but it is very good thing, right? Okay. And forceps as such, general forceps is Dr. Ashish is taking. Ask the assistant to lift the baby horizontally, not much extended. And then from the ventral aspect, right? You first pass your hands, then one blade, first left blade goes on the left side of the maternal pelvis, then second blade on the right side of the maternal pelvis, same as like forecoming head. Left blade, right blade. There is one special forceps because the baby's trunk comes, there is a shank has a curve, Edmund Piper's forceps. But you can use any long forceps. Even we have done with a short forceps also, outlet forceps also, depending on the size of the baby. But long forceps is good. Edmund Piper is the best, but that is there. So keep right left blade first, right blade, lock it, and wait for contraction to come. And when you actually deliver, believe me, it is very easy because the rest of the baby is out. You are not pulling the whole baby, just head you are delivering. Head you are delivering. It is very easy for because I have done for coming head hundreds, but after coming head very few. But always that impression is in my mind that for after coming head, if you are able to catch it, and then cord is there in between, don't go get entangled with the cord, right? The limbs are there, but cord is going there. So it does not come in way, blade goes this way, right blade goes this way, lock the blades, and when with contraction, same downward and forward, down, forward and upward, like this. Down and somewhat backward initially because head is slightly high, right? So after coming head is a problem. And then because of hurry, tension, people indulge in an early delivery, early traction, then it does not come out. You become more panicky, you pull it more. There is a stretching at the necks, all injuries of the brachial plexus, and you have a bad impression. And people give up. Okay, now which delivery I cannot do. It is there are problems, but you should do it a perfect way with a right waiting, and when the subacute hairlines, nothing happens 7, 8, 10 minutes. Baby does not die. Right. I'll have this in mind. Have my words that I have done many breech delivery and not lost any. So that is very important. Right. So that is very important. Slow, controlled delivery. Always slow, controlled delivery. So for right, there are two things which is not practiced: Brecht maneuver and Prague maneuver. The Brecht maneuver, right, which was there in European countries, Brecht maneuver. So that goes with the right. I tell you this how it went. It from the delivery of the trunk, the baby is extended on the mother's abdomen, and then that extension of the baby delivers the baby head. But Brecht maneuver, European countries were favored. And Prague maneuver, it is for occipito-posterior. I mean, sacro-posterior. So in this, right, combination of Burns Marshall and MSV. Hand, I'm putting this, and left hand I'm passing with the inside to shoulder grip. So this way baby is delivered. This is Prague maneuver for sacro-posterior, that is head occipito-posterior, after coming head. Okay, so that is right. Prague maneuver. There are many maneuvers, but these are very more. And this is Brecht maneuver. Forget that Burns Marshall is a weak tractor. You practice Burns Marshall. Okay, sorry. MMSV technique, most rewarding. For sure, you can do it. It is the best, but otherwise you have not learned all PGs, and then that's why leave it aside. Only Mauricio Smelly with technique. Still, there is a problem that there are some clues. One, the oblique diameter of the pelvis, oblique, right? From inlet to outlet, this is 12, 12, 12. So if you are keeping the occipito anterior, slightly rotate it on one side and then give traction for after coming head. Even Burns Marshall, we are not able to deliver. Keep the baby slightly oblique because oblique diameter is good. Because in inlet, AP is less, right? In outlet, transverse is less. Interspinous, intertuberous. In inlet, AP diameter, conjugate diameter. So, but oblique are 12, 12, 12. So keep the baby slightly oblique and give traction, you will be able to do it. Second, like shoulder dystocia, give macroverts, right? Both lower limbs flex, hyperflex, abducted and extended. This increases the diameter. Like in shoulder dystocia you are doing, you can do it here also. If you are finding difficulty or there is a trapping of after coming, by chance premature baby comes out and then some cervical, right, ream is there, give epidosin, IV relaxant, IV some, right, nitroglycerin or epidosin, cervical relaxant, or even, right, it is said that you can put Brussels incision. Theoretically, you can speak out that because Brussels incision in a forthcoming head is a problem, but in after coming head, it does not cause any problem. Okay, so I think my time is over, right? I am not overshooting my time, but the right mechanism of labor is very clear. And for management, I've given some clues. There may be some right based tips from other consultants. If any question you can put in right in the chat box, and I'll be happy to answer it. Thank you, doctor. Thank you. I think I have finished in time. There was some problem in holding the baby because no assistant. I have to hold the baby. You cannot conduct the delivery single-handed.
Yes,
In breach, always. Breach,
always
always
a
you require
problem in
help.
online teaching. Yes, that is a problem of online teaching. We
Yes.
understand that. It's very difficult to do justice to the visual effect as well as the, the lack of assistance.
But these are PGs, so they can understand.
Yeah, they will understand, yes. And thank you very much, Professor Doshi. I think that it was a very comprehensive and beautiful and sweet presentation on breech, assisted vaginal delivery of breech and the various techniques of breech delivery. You have highlighted the mechanisms that we usually apply these days, like the Mauritius Smelly Witt technique or the forceps. And you have carefully alerted the PGs about the problems of other methods which we used to do in our student days but rarely practice these days. Thank you very much for excellent. Just one suggestion about the aftercoming head of the breech. You see, whenever we say you have the model with you, that's why I'm suggesting this to you. You can show this to the students, that when you apply forceps at the aftercoming head of the breech, it's a good practice. I have seen that wrap the baby in another towel which is provided,
Yes.
and
So that
bring it up.
hands does not come down.
Like the hammock. So
Yes,
the forceps application becomes easier,
Yes.
Otherwise the hands and the legs and the baby's parts will be
Yes.
obstructing your view, and the application of the forceps, I think it's a good suggestion. Instead of
Yes, sir.
engaging
No,
the
we are doing that way only. We are doing, but because I could not show it here. And always, because the hand should not be like,
Yeah.
Right.
Correct.
Sorry.
Then the
Yes.
application becomes easier.
Not only the baby horizontal, but also the upper limbs are covered by the towels to lift it up.
Correct. Thank you very much. Thank you very much.
Thank you.
Sir, excellent presentation, and very good. Hope the PGs have benefited from this. And any comment from the teachers? Professor Kiran Pandey would like to say something on this. I will quickly move into the.
Oh, it was an excellent presentation. Apni residency yaad aa gayi. Our teachers used to teach like this only.
Thank
I
you.
was just remembering that same time. Wonderful.
Thank you, madam.
Thank you very much, Dr. Doshi and Professor
And
Doshi.
then the tip when you told oblique में लेके थोड़ा सा करना, this तो I mean I heard first time. That was a good.
Yeah. So I think Hafizur, please call the students now, and thank you very much, Professor Doshi. Once again.
Here. Students are here.
Yes, sir. Ashok sir, we can tell the students to present.
Yeah. Just
so, Dr. Boishali and Dr. Prerana, you can share your screen and introduce yourself and start presenting. I'd like to request the faculty
how much time we do have to give it to the case presentation, because there is a instrumental delivery part also is there.
Yes. I'll tell you the time. The official time is 11:30 to 12:15 p.m. for the Professor Doshi's presentation, which he has just crossed, by 15 minutes. And the next is 12:15 to 1:20 p.m. That means we'll finish by 1:20.
Sir, we can, Ashish sir, we can extend to 1:30, I think, sir.
1:30.
So,
if needed. Otherwise, it's okay.
Yes, ma'am. Up to 1:30 is okay.
Because you have only half an hour left for the forceps. That will not be good this thing for the good enough time for the forceps. So we'll try to finish by 1:20, and if needed, we can extend it.
Right. Absolutely right, doctor.
Sir, we have Dr. Nitin Raithata. Sir, you are there?
Yes, sir. I am here.
Yes, sir. Sir is a prophet. Yes, sir. And Dr. Ajit Nagarsekar. Good afternoon, sir. Are you there, Dr. Ajit, sir?
I think he is there in the audience link.
Why he was not sent the faculty link?
He was sent. Yeah.
Or the technical people can convert it.
Mr. Manoj, can you take care of this, or is to take Dr. Ajit Nagarsekar to the faculty?
I am seeing his name in participant list.
Anyone from the supporting team?
Yes, sir. I am here. Just announce him.
Dr. Ajit Nagarsekar, please join in the faculty link, or you can bring him in the faculty.
Okay, just a minute, sir.
because you have sent the link also. Yeah, Dr. Prerna, Dr. Vaishali, you can share the screen and introduce yourself, start presenting. I would like to request the faculties to take over, please.
Yes, please make it
Please make it a PowerPoint. Slideshow.
Very
Yeah.
good afternoon to all the faculty present here. Me, Dr. Prerna and Dr. Vishali will be presenting a case on adolescent PCOS. So we are presenting a case on Miss B, 17-year-old female, student of 12th class, resident of Kalanur, Rohtak, and belonging to lower middle socioeconomic status by modified Kupuswamy scale. Her chief complaints are she has irregular menstrual cycles since last 2 years and she has excessive hair growth since last 6 months. History of presenting illness. Patient presented with history of prolonged cycles coming at an interval of 2 to 2.5 months since last 2 years. Now she has history of amenorrhea of 3 months. Her menses was associated with heavy menstrual bleeding, wherein she had to use 5 to 6 sanitary pads per day and bleeding lasting for 7 to 8 days, which was painless. Patient also gives history of excessive hair growth, mainly over her upper lip and chin since last 6 months. This complaint was insidious in onset and it has gradually progressed. Patient also gives history of weight gain over past 1 year. Her previous weight was 60 kg and now she is 68 kg. That means she has gained over 8 kgs. Now, there is no history of acne. There is no history of fatigue, cold sensitivity, constipation, or swelling in the neck. There is no history of any palpitations, anxiety, or diarrhea. There is no history of weight loss. There is no history of discharge from nipple. There is no history of fever, chronic cough, malaise, or night sweats. There is no history of any headache or visual symptoms. There is no history of any feeling of lump per abdomen. There is no history of deepening or hoarsening of voice. There is no history of any stress or excessive exercise. There is no history of any chronic systemic illness. No history of any drug intake. Menstrual history. She attained menarche at 14 years of age. After menarche, her cycles were regular at an interval of 28 to 30 days, lasting for almost 4 to 5 days, with soakage of 2 to 3 pads per day. There is no history of dysmenorrhea during these cycles, no history of passage of any clots. Her last menstrual period, as told earlier, was 3 months back. Her past history, there is no history of tuberculosis, diabetes, hypertension, asthma, any thyroid disorder or any allergy. There is no history of any previous surgery. There is no history of any blood or blood products transfusion. No history of any drug intake. On personal history, she is student by occupation. She has normal appetite, normal bowel and bladder habits, normal sleep-wake cycle, no addiction, and she is not sexually active as of now. Her dietary history, she is vegetarian by diet. Her total calories intake is 2,350 kilocalories per day and total protein intake is 42 grams per day. Her family history, there is no similar history of these complaints in the family. There is no history of any malignancy in the family. On
let's, before we go to the examination, let's go back to the history.
The history.
Yes, ma'am.
I think Dr. Nitin will also
Yes.
agree. Let's talk about the history first. So you mean to say she has attained menarche at 14 years and she's now 17 years and for 2 years she's having these
Yes, ma'am.
complaints. And
Yes,
the main
ma'am.
complaint you said that the prolonged cycles.
Yes, ma'am.
And along with that, the heavy menstrual blood loss is increased
Yes, ma'am.
for 7 to 8 days.
Yes,
Right.
ma'am.
And what about this hair, hair increase? You said chief complaint, excessive hair growth.
Yes, ma'am.
Will you
has
elaborate on this?
Yes, ma'am. She has to shave on more frequent basis, ma'am. Previously, she was shaving on once or twice.
No. That is the main. First thing, where are these excessive hair growth?
Okay, ma'am.
Locations.
Is it important or not?
Yes, ma'am. They are important, ma'am. She has presented to us with the more hair on upper lip and chin specifically.
And anywhere else, did you ask?
Ma'am, we asked, but she did not complain. But on
What did
examination,
you ask?
What are
Okay.
possible
yes, ma'am, we asked for upper abdomen, lower abdomen, chest, and back and thigh, and ma'am, medial side of thigh, upper back and lower back, and as well as upper arm.
Okay. What about the how much is the hair? Anything else?
texture?
Ma'am, she is saying they are coarse, thick hair, and also, ma'am, she says she has to she use shaving method for ma'am the removal of these hair, and she's saying over the last 1 year, over the last 6 months, the frequency of shaving has increased, ma'am.
So when did she start shaving? I mean, as soon as she grew the hair.
Ma'am, since
You
last 1 year she has been shaving, ma'am. She is getting this. Previously she was using ma'am other methods. Now she's using shaving, ma'am.
I think on examination you will tell us the scoring by the
Yes, ma'am.
Mervyn
Yes, ma'am.
Galway.
Yes, ma'am.
Okay,
That has
so
been
that
covered
we'll
in.
see later on.
Yes,
So
ma'am.
at the moment you have a coarse long hair on upper lip and
And
chin.
chin.
But not on the chest, not on the abdomen, upper or lower at all.
Ma'am, she did not complain, ma'am. But when we examined, there were coarse hair, ma'am, over her lower abdomen, ma'am, as well as medial aspect of thigh, ma'am.
Okay, right. Okay. So you found it. You found it on the breast also?
Yes, ma'am. Breast, it was, ma'am, score 3, ma'am. And abdomen, ma'am, it was score 4, ma'am. And lower abdomen, ma'am. And rest, ma'am, upper chin and this chin and upper lip, ma'am.
But as you now tell the score, so what is the cutoff?
Ma'am, 4 to 6, ma'am.
So you said 4 only or less than 4, 3.
Yes, ma'am. Less than 4 is.
I mean, dogmatically, you cannot keep it. Of course, there are these suggestive features.
Yes, ma'am.
And what about?
Kiran madam, will you go to the? We will go to the this thing score when we come to the examination
Yeah,
part.
that is what I said actually.
Yeah,
Ki you will tell. So, but when they said, so I said I asked it.
Yeah, right.
I mean, otherwise they will come. That will come into the examination.
In the examination, in the meantime, I'd like to go back to the menstrual history. You know, menstrual history is
More important.
how much important menstrual history is in adolescent PCOS. I suppose you know the PGs. I mean, it's extremely important these days. I mean, it is almost the diagnostic point of adolescent PCOS. In that light, you must take the menstrual history properly. You said menarche is at 14 years.
Yes,
Is
sir.
it the normal time of menarche?
Yes, sir. Yes, sir.
In
So
nowadays, what
the
is the
usual age
pattern?
these days?
Okay.
Sir, 10 to 13 is usual age these days, sir.
Okay. And see, this age is very important. And coming back to the age, we always take the patient's verbatim statement or her mother's statement about the correct age. But previously, we used to confirm the age by some other methods. That is not necessary these days because they have to go through the biometric examination when they make the Aadhaar card, and therefore we tend to believe on the Aadhaar card. This thing,
Yeah,
age.
nowadays that is not
Simple.
important. But of course, there are other points in the history. I mean, the menstrual history detail.
So that is about the age, and then you have to specifically ask about the cycles. You said the cycle interval was 20 to 30 days. Was it always? You said irregular menstruation.
Sir, these were previous cycles, sir. Before 2 years, sir.
Okay, now the cycles are.
Sir, 2.5 months, sir. She said that they are prolonged cycles, sir. She has menses after 2.5 months, sir.
What are the other patterns can be there in PCOS patients in the menstrual abnormality?
Sorry, sir.
Which are the other patterns can be there?
Sir, she
as a
can have
presentation other than this, what is seen in your case?
Yes, sir.
What are
She
the
can
possible?
have, sir, amenorrhea. She can have oligomenorrhea, or she can have, sir, heavy menstrual bleeding as well.
What is the usual percentage of heavy bleeding? Is it the most common thing?
No,
or,
sir, no, ma'am. It is the least common usually. We usually get
hypomenorrhea versus oligomenorrhea.
Sir, hypomenorrhea is when the cycles are prolonged, sir. When the sorry, sir, the volume is less, then it is hypomenorrhea, and if cycles are prolonged, then it is oligomenorrhea. According to sir new classification, we are not using these terms. We are not using these terms. We are using either scanty menses or prolonged cycles.
Okay. So I think you will agree with me that if I say that the cycle was always nowadays, I mean, last say 1 year or so, or 6 months, it is more than 45 days, isn't it?
Yes, sir.
Yes, sir.
That is
Yes,
very
sir.
important. Okay.
Or
So
after.
that you have to write clearly that the present cycle, how much is the present cycle, you haven't written here. You have to write about the present duration or interval of the cycle. It's very important, you know.
Okay, sir.
So it has to be either more than 35 days or more than 45 days. In case
45. So it is more than 35, sir.
To
more
label
than
it
that.
into that
So
category.
you have to mention that
Okay.
here in the
Okay.
menstrual history. That's
Okay.
extremely important. Dysmenorrhea, passage of clots is okay. Last menstrual period was 3 months back. That's also okay, but preferably you should mention the date. But anyhow, you must always write about the cycle because the cycle is extremely important these days.
Yes, sir.
Okay. So that is about the menstrual history detailing. And let us go to the examination now.
Yes, sir.
I think let's discuss a little bit of the no history, what they have taken. So
Okay.
from what all you have ruled out. Yes, no history of acne is okay.
Ma'am, no history of fatigue, cold sensitivity, constipation. That
Please
rules.
go on explaining why you are taking which history and what is the importance of it.
Okay, ma'am. Ma'am, no history of fatigue, cold sensitivity, constipation to rule out hypothyroidism, ma'am, as these are common in hypothyroidism. No history of palpitations, anxiety, and diarrhea, ma'am, to rule out hyperthyroidism. Then, ma'am, no history of weight loss for genital
I think
tuberculosis.
once you are telling she has gained 8 kg weight, so
Yes.
now this history becomes irrelevant.
Yes, ma'am. Yes, ma'am.
On one side, you are saying that she has already gained 8 kg.
Yes, ma'am. Sorry.
Mm.
No history of discharge from nipple to rule out, ma'am, any cause of hyperprolactinemia. That is, galacturia is a sign of hyperprolactinemia, ma'am. No history of fever, chronic cough, malaise, or night sweats to rule out genital TB or any other form of TB, ma'am. No history of headache or visual symptoms, ma'am, to rule out pituitary causes as well as hypothalamic causes, ma'am.
Genital TB can present with which symptoms?
They can have amenorrhea,
Amenorrhea.
followed by periods of heavy menstrual bleeding also.
And abdominal pain or some swelling.
Yes, ma'am.
Yes,
Yes, sir.
lipomenorrhea.
Usually lower abdominal
Some
pain,
can
sir.
be there.
Can be vague.
Yes, sir. Then, so there is no history of feeling of lump per abdomen for any pelvic mass or adrenal mass.
tumors or ovarian tumors to rule out that.
Then, sir, no history of
Okay.
deepening or worsening, sir, for virilization, signs of virilization, sir. Then, no history of stress or excessive exercise because they can lead to amenorrhea by suppression of hypothalamus.
Hypothalamic causes of
No history of chronic systemic illness. They can also cause amenorrhea. No history of drug intake since she can be taking any steroids
Medical.
or other drugs.
to rule out his
Drugs means allopathy drugs, or we should also ask about the Ayurveda,
Ayurveda, yes,
homeopathy, or any
both.
other pathies.
Yes, sir, both, sir. So she was not taking any allopathic as well as Ayurvedic.
Does she taking any nutritional supplements? Because nowadays there is because she has gained weight, she may be
No,
taking
no,
some
sir.
nutritional supplement like protein powders or some other
No,
different.
sir, no, sir. As of
People
now,
are
she was
coming
not
up with
taking.
the part for weight loss. So that can
What
be
can be
interfering.
the problem with these nutritional supplements which Doctor is saying?
So
They can have
steroids and anabolic steroids.
Steroids,
Mostly
and
they have anabolic steroids, ma'am. They can increase the androgens as well, leading to these symptoms, ma'am.
Okay. So you have ruled out all these causes of the other causes of which can present like these complaints. Go ahead.
What are the features you look for, apart from the hair growth at abnormal places, of the signs of hyperandrogenism? You have to know that.
Yes, sir.
In
Either
adults,
from history or from examination.
So hirsutism, acne, and sir,
Androgen-
female pattern hair loss is not so
Anything
common
of the
in
neck?
adolescents, sir. So we are not taking that into account.
And I think
Okay.
when you will come on examination, you will tell us
Examination will
acne
give.
because many times they don't give history, but on examination
Marks
you
may be
may
there.
find it at certain places. So
So any family history that you need?
Yes, sir.
There is no family history,
So
sir.
presently in our case,
neither
there is no family history, but otherwise there can
no
be
family
history of
history of
diabetes
what?
mellitus.
What?
diabetes
Diabetes
mellitus,
mellitus,
hypertension,
hypertension,
metabolic
renal-
syndrome, or
metabolic-
dyslipidemia, ma'am. It can be there, and PCOS also,
In
ma'am.
mothers and daughters, this is
Daughters.
most common, sir.
Okay.
Okay.
So what is
Any
this?
history from the mother's part? About our
Diabetes
menstrual-
and
The mother is not giving any such history of irregular menses.
PCOS, like symptoms that she doesn't have.
Is mother's
In the
menarche
family
important?
history,
If
which
she
you have
can remember
shown?
Family history.
mother's menarche or any sibling that she has.
Sir, she didn't give any history of similar complaints in any of members.
Did you ask?
Yes, sir.
Yes, sir. We asked in the siblings. Sir. Siblings as well as in mothers.
Okay.
Okay, but then you have not mentioned it in detail. No similar history is very short thing. It's a vague term. You should have
Specify and highlight.
elaborated these points. And another thing, did you ask anything history in during pregnancy? Anything happened? Is it important? And if it is important, what is the importance?
Ma'am, PCOS, if it is there in the mother, can lead to adverse outcomes in the mother as in the form of gestational hypertension, preeclampsia, or as well as
Actually,
gestational diabetes mellitus.
I'm asking something else. There is a theory that because of certain factors during the pregnancy period, this
Exposure
can be
to-
there.
Exposure to androgens or steroid, if mother has been exposed to some form of steroids during the antenatal period, that can lead to kind of adrenal hyperplasia in the female child.
What about the FOGSI hypothesis? What is that? And how it is relevant in cases of adolescent PCOS?
Sorry, ma'am.
It's basically intrauterine programming of the fetus. And what type of intrauterine programming into the fetus can cause adolescent PCOS? Both undernutrition and overnutrition of the fetus. And of course, the thing which you were saying, like any significant family history, even if there is a genetically predisposed female not presenting with actual adult PCOS clearly, may have intrauterine programming in such a way that this child is predisposed for adolescent PCOS. So that is what is becoming very important thing, that intrauterine programming for these fetuses, because that will go a long term for her into a prolonged later on metabolic syndrome and all that. So that is very important to be evaluated. That does she had what was the weight of the baby when she presented? Was she told that it was there is an intrauterine growth restriction, or there was a baby was very fat or something? So these factors should also have been taken specifically in these cases. And why did you ask history of any malignancy?
Ma'am, for genital malignancy, ma'am, ovarian cancers can run in family, ma'am. And even, ma'am, adrenal tumors have genetic predisposition.
No, but
related to PCOS.
Yeah, some of them may present as
Endometrial cancer can
Initial,
be there,
yes,
ma'am.
rarely they may. It
very
may be
rarely.
some correlation.
I think we will quickly move to the examination because time is
Examination.
out now.
Okay, come, go ahead.
So myself, Dr. Vaishali Gautam, I would like to proceed with general physical examination. My patient is conscious, cooperative, and well-oriented to time, place, and person. The patient is well-built and nourished. There is no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy or edema. Her scalp hair is normal and her skin appears to be normal. She has mild hirsutism according to modified Ferryman-Galway score. Her score was 12. There is no thyroid enlargement. Axillary hair shows Tanner stage 3. Pubic hair shows Tanner stage 4. On breast examination, it was
going
Tanner.
into breast, could you show us how did you calculate the Ferryman-Galway? Galway spelling is first of all wrong. Ferryman-Galway score of 12. You said she had hirsutism according to her complaint, only upper lip and the chin. And on examination, where else did you find the hair?
Sir, on examination, her hairs were on the upper chest, lower abdomen of lower part of abdomen, on the inner aspect of
You
thighs,
have written
the
that.
upper aspect back, and outer aspect of arms.
Have you written them?
Sir, we have not shown it separately with the
But
image.
once
better
you are
method is
saying
to-
the score so high, then
The
it should
score
have
is,
been.
if you do not write it down here, then what happens? The examiner tends to believe that whatever she has spoken out about, that means the upper lip and chin, that doesn't constitute score of 12.
No, sir.
Yes,
They
sir.
were on upper chest and lower abdomen as well
But
as
you
on.
must write them. You have to write in your findings. That's why the examination is very important. You have to write the findings of adult type hair. Where have you found them? Hair
Ideally, the good method is to draw the picture, simple, and mark the score at each area, like chin, lip, or upper arm, or lower abdomen, or a chest part. Just mark some part and put the score there. So it's a good way to represent the.
that is much better if you can do that. But in that exam tension, they may not draw. They will be able to draw a picture of a human being. I know that.
It's simple.
Doesn't matter.
Schematic.
Doesn't matter, doctor. They can just pointing that play part where they.
Schematic.
That will be suffice.
You just write the
no issue. Remember this into your exam. That
the exam
this
is important.
You have to tell that. Okay.
Okay.
Go ahead.
Because she has only this feature of hyperandrogenism, isn't it?
Yes,
You have to highlight this. Very important. This is.
Okay. On breast examination, it was Steiner stage 4. Bilateral breast appear normal. Nipple and alveolar complex appears to be normal, and there was no discharge from the nipple.
You had said some hairs were there on the breast also.
Not in the examination.
Okay.
You just in interaction with the madam, you were mentioning about some hair growth on the breast.
Yes, there was, sir. There were thin hair, sir. One score we have given.
Okay.
Length of the hair, does it matter?
Yes, sir.
Yes,
It
ma'am.
should be
If it is
more
more
than
than 5 mm.
0.5
So
centimeter.
something you should say so that we are convinced that it is a androgenic feature typically, right? So
Okay.
that should be mentioned, beta, very clearly.
Okay. Okay.
Her pulse rate is normal, 76 beats per minute. Blood pressure is of 110 by 80 millimeters of mercury. Temperature is 98 degree Fahrenheit and respiratory rate of 12 per minute. Weight of 68 kgs. Initially, her weight was 60 and she has gained weight of around 8 kgs in this 1 year. Height of 160 centimeters, and this making her BMI of 26.5 kgs per meter square. According to which she is overweight. Her waist circumference is 84 centimeters, hip circumference is 80 centimeters, making her waist hip ratio of 1.05.
Is it normal?
No,
No,
sir.
sir. She has
What is the normal range?
obesity.
Sir,
Normal range?
normal range of
Waist hip ratio.
so if it is more than 0.7 to it's raised.
Okay.
And
And what is just to wish one thing to any significance of blood pressure here?
Yes, sir.
Yes, sir.
Sir, for PCOS, we have to
rule out
measure
any major
blood
BP and
pressure.
rule out metabolic disorders because she is a candidate that she can have metabolic disorders.
Baseline blood pressure you
Yes,
have to
Baseline
know.
we should know so that we can
Monitor
measure
further in the
annually,
Right.
sir. Annually, we have to measure.
Okay.
And the time is short, otherwise, I mean, like BMI also should be, I mean, you should have the latest BMI
Yes,
Indian
every
criteria.
Yes,
The
yes, ma'am.
reference
BMI
basis.
can be measured at every visit, ma'am, when patient comes, and BP should be measured at least annually. We can modify
Normal
the.
range bata do bas, like that is,
Okay, ma'am.
what is the upper limit these days, which is considered?
So, ma'am, it should be less than 130 by 85, ma'am.
I'm asking BMI, not
BMI.
BMI, okay. 18.5 to 24.9, ma'am. For ma'am, actually for Asian
Asian
women,
is
it
more
is
than
less than
22.
ma'am, it is from 18.5 to 22.9, ma'am.
Yes, that is what I was saying. 24.9, we were used to take it earlier, but now
Yes, ma'am. For Asian women, it's 22.9, ma'am.
26 point, I think 5 or something, what you said, is
Yes, ma'am.
26.5.
Yes.
0.5.
She comes under obesity as per Asian guidelines, ma'am.
But
But
according to
So we
the
have to talk these guidelines only presently. Okay.
Okay.
on systemic examination, on cardiovascular system examination, it is normal. S1, S2 heard, and there was no added sounds. Respiratory system examination, normal vesicular breathing were seen. On neurological examination, there was no abnormality detected, and on genitourinary system examination, no abnormality detected. On per abdomen examination, on inspection, there was no visible scars or any distended veins. On palpation, abdomen is soft, non-tense, non-tender, and there is no organomegaly and no mass felt. On local examination, vulva appears normal as per her age, and pubic hair, which was Steiner stage 4, it was coarse, pigmented, dark hairs, which was present over her vulva. So my summary.
You mentioned just before that. Have you mentioned about the neck examination?
No.
Sir, we have mentioned head to
thyroid
toe.
gland.
In head to toe,
So we
toe
have to-
surgery.
No, but something doctor wants to hear something specifically.
There is no
Should have
acanthosis
either no or
nigricans.
Yes,
There is no
yes.
acanthosis nigricans.
What is
that
the
should have
importance?
been.
Sir, it's a sign of insulin resistance, sir.
Resistance.
There were no skin tags as well as acanthosis nigricans.
Okay.
Right. So summary we know, I think, so there's no need to waste time into that. So your final diagnosis is?
So we are
17 years
probable-
old girl with the adolescent PCOS, ma'am.
This is our probable diagnosis, sir. We will confirm it after doing some investigations.
Investigation. So what are differential diagnoses then?
So differential diagnosis, sir. First is hypothyroidism.
Followed by, we can think of hyperprolactinemia. If she has any history of nipple discharge, late onset congenital adrenal hyperplasia, we can think of Cushing syndrome, because they also present with the similar complaints of menstrual irregularities as well as features of hyperandrogenism. So we need to rule out all the cases where the patients can have same complaints. And we can think of androgen secreting ovarian or adrenal tumors.
Okay.
What
So
is ARN syndrome?
Ma'am, hyperandrogenism, insulin resistance, and acanthosis nigricans.
Combination
Where we can, which we usually encounter in the patients of PCOS.
Yeah. So you should have, that is why importance it becomes.
Yes.
Right.
so what investigation you will do to rule out all these differential diagnoses and come to your provisional diagnosis?
Final diagnosis.
So nowadays, according to recent guidelines, if patient is having two symptoms, which is major symptoms of menstrual irregularities or clinical hyperandrogenism, we need not to do other investigations if we are like she is having clinical hyperandrogenism. But if she is having severe hirsutism, where we can encounter similar conditions in other situations, then we need to rule out with using blood test. And nowadays, we are not using any pelvic ultrasound also until we feel that values of lab investigations are markedly raised 2 times above the baselines. Then only we are supposed to do pelvic ultrasound, or any mass per abdomen we are feeling, or any patient giving history of early onset or acute
Rapid
onset of
progression.
hirsutism or rapid onset. Then we are performing investigations. But in our case, patient already came with such investigations with her reports. In our patient, we only did urine pregnancy test, which was negative, as she was giving history of amenorrhea of 3 months. And rest, we did not do any investigations by our side, because we were having all the clear-cut history. According to the history, she was having features of PCOS, which we need nowadays to make a diagnosis of PCOS. But in our patient,
she didn't bring any ultrasound, because everyone comes these days with the ultrasound as the
No,
first
ma'am.
report. So didn't she bring ultrasound? It is very unusual.
Ma'am, she
Maybe-
did
maybe
bring,
And
she
ma'am.
has-
mother comes with the history of the mother. My daughter has cysts.
Ma'am,
she
actually
did
she did
bring-
bring, ma'am, but we did not put it in our slide,
Maybe
ma'am.
maybe she has come with, and it is kept secretly under her pillow.
That is what is.
no,
Anyway,
she had brought, ma'am.
We did not.
Can you just tell me why ultrasound is not considered into the diagnosis of adolescent
Ma'am,
PCOS?
nowadays, because of this multifollicular change, cyst, which we see in the ovary, can be as a normal finding of pubertal adolescent findings. So we are not taking it in account as an multicystic ovary as a diagnostic factor, which is there in the Rotterdam's criteria. So in the
What are
adult,
the classical differences? What changes has happened between adolescent PCOS and adult PCOS?
Yes.
ma'am, in adolescent PCOS, we are taking these two main criteria to make a diagnosis of PCOS, that is of menstrual irregularities and hyperandrogenism. Whereas in an adult, 2 out of 3 criteria of the Rotterdam should be fulfilled to make a diagnosis of PCOS, where we are taking ultrasound also as a main criteria, where according to new guideline, we are taking more than equal to 20 follicles per ovary of size 2 to 9 mm of ovarian volume more than 10 ml, which previously it was 12 follicles per ovary.
Right. And that is, would you like to mention it by
Anything else?
transvaginally or
Transvaginal.
And transvaginal is
Transvaginal.
always
Transvaginal.
preferred, ma'am,
Preferred.
until
Right. So
the patient
adolescent
is not.
PCOS, and is there any value of AMH into it?
Ma'am, in adolescent PCOS, there is no role, because there is no definitive evidence of AMH if we are performing in adolescent, but in adult we can do. But if we are performing both AMH and ultrasound, it can sometimes lead to overdiagnosis. So it is
they
presumed
should
that we
not
can
be.
perform either of that, either ultrasound.
AMH is still not the
Still not.
diagnostic
It's
guideline.
not. It is not in diagnostic.
Can be done.
Can be done, ma'am.
But it
Okay.
is
In
not.
place of ultrasound, ma'am.
Prerna, isn't it? Prerna, yes, Prerna, can you tell me? You talked about the Rotterdam classification consensus.
Yes, sir.
That happened in which year?
2003, sir.
Okay.
But when did
After-
modified came?
2018. 2018, sir.
What was the
And-
modification?
So the number of follicles was increased from 12 to 20, sir.
And also initially it
And-
used to be hyperechogenic
Echogenic
stroma, ovarian stroma.
that has been removed.
Removed.
No, I'm
that
talking
was
about
the
I'm talking about the
ultrasound
other
criteria
features,
removed.
not about the ultrasound features, but
Other.
other criteria also they modified, and that's a very subtle difference between the erstwhile Rotterdam classification, Rotterdam consensus in 2003 and the 2018. What are the changes?
Sir, in 2018, they have divided it into 4 phenotypes, sir. So either the patient can have 3 of them, all of them, or she can have either ovulatory dysfunction plus hyperandrogenism, or this polycystic ovarian morphology in one of them. So they are 4 phenotypes, sir.
Fourth one.
Fourth one is, sir, without hyperandrogenism, only
Only
PCOM
ovulatory
and
dysfunction,
ovulatory
yes.
dysfunction. But sir, Androgen Excess Society, they do not consider this as PCOS when there is no hyperandrogenism.
Yeah, yes, androgen excess society. What do they recommend? What do they say? That came into
They say at least hyperandrogenism should be there for making diagnosis of PCOS. Either polycystic ovarian morphology can be there or ovulatory dysfunction can be there, but hyperandrogenism has to be there. And for polycystic ovarian morphology, they have increased the follicular number to 25, sir. It's not 20, it's 25.
Okay, so the important difference between this Rotterdam and this androgen excess is that
Hyperandrogenism should be there, sir.
in Rotterdam, we used to select 2 out of 3.
2 out of
But
3.
Any out of
You need
3.
to fulfill all the
Yes,
three.
Any 2 out of 3.
Yes,
No,
sir.
all required was in NIH. That was different. That was previously. That is gone. But the AEPCOS definition, that means androgen excess, they
Sure.
recommended no, hyperandrogenism must be there,
Yes.
and oligoamenorrhea or anovulation and polycystic ovaries, any other, one of the 2.
One of them can be.
Another two. Another.
So 2 of 3 is gone now. 1 is fixed. Like, have you seen the signature of treasurer in a check? Treasurer is always concerned. And then either the president and the secretary, either of them, previously what used to happen, anyone can sign, either president or secretary or treasurer of your society. But now treasurer is fixed and the other 2, any one of them. So that is the important difference between androgen excess and the, so hyperandrogenism is given maximum importance apart from the menstrual disturbances, menstrual cycle. Can you tell us more about what are the cycle definitions of adolescent?
Yes, sir.
cycle?
After 1 year of, sir, up to 1 year of menarche, the ovulatory dysfunction and the anovulatory cycles are common. So they are not inclusion of PCOS. After more than 1 year, up to 3 years, sir, if cycles are less than 21 days or more than 45 days. And after 3 years of menarche, if cycles are anytime less than 21 days or after 35 days. Or there is any time amenorrhea of 90 days, sir.
After 1
After
year.
1 year of menarche, or if the primary amenorrhea till 15 years or
3 years post
3 years after thelarche.
After therapy, the 3 years.
3 years.
Okay.
These all are ovulatory dysfunction or the
Menstrual
menstrual
irregularities.
So
irregularities.
now you understand why this patient falls in which category. The importance of menstrual history, now you will understand. What was the age of menarche of this patient?
14, and she presented to us as 17. So she has crossed the 3 years.
isn't it?
Yes, sir.
Yes,
Her
crossed 3
cycles
years.
are more
3
than
months of
35 days,
amenorrhea.
sir. So
You have to mention that she
okay.
falls in the category of more than 3 years.
3 years, and her cycles
And-
are more than 35 days.
And whenever you talk about amenorrhea, you must mention that post therapy 3 years she doesn't have the amenorrhea, but she has no cycle more than 90 days.
90
All
days.
points you must write in the menstrual history. So whenever you're dealing with a case of adolescent PCOS, you must be very, very careful about the menstrual history and in detail. Also, your hirsutism examination must be in detail. Okay, because that was the only feature of hyperandrogenism, clinical features of hyperandrogenism. Okay, are you happy with the diagnosis of hyperandrogenism in this case?
Yes,
Before
sir.
coming to the final diagnosis, would you like to confirm that whether she is really a case of hyperandrogenism or not? And what do you investigate for that?
So we would like to confirm hyperandrogenism by doing blood test. Serum testosterone we would like to do. Free testosterone levels we also can do, but laboratory values are not so exact in the case of free testosterone levels. So still we prefer total testosterone levels only. And to have more accurate value, we can go with the free androgen index, that is total testosterone divided by SHBG into 100.
From free androgen index also you can find out the free
Yes, sir.
testosterone.
Yes.
So ideally, free testosterone we do not measure. We just ask for
Right.
total testosterone and then we go for the
Free
Free
androgen.
androgen
free
index.
androgen index. Okay. Any other suggestive features of suppose you see that most of the cases we'll see that the testosterone level is normal.
Yes.
So what do you do then?
So we can go for DHEA
Sir,
and
DHEAs and androstenedione test we can do if the levels are normal, but still she is having clinical hyperandrogenism.
For
And if so, to rule out other causes like
adrenal tumor,
tumors,
more
androgen
specific for
secreting
adrenal tumors.
But if the
Okay.
testosterone level is already not raised, what are the chances of developing adrenal tumor? And
Usually.
Which other indicator is there for the adrenal tumors?
adrenal tumor. One, you said DHA and
androstenedione which come from the peripheral conversion. So in that level, in that case, testosterone can be normal, but androstenedione can be raised.
can be raised.
But
Yes.
I think specific is DHAS.
DHEAs, sir,
DHEAs,
for
100%
adrenal.
from
Yes.
the adrenal.
Androgen
So
can be
you
good.
Adrenal
have to have a measurement. If you suspect a case of adrenal involvement, then either you should go for a DHAS measurement over and above the testosterone, and also in cases where the testosterone level is normal and you still suspect the adrenal involvement could be there, you must have DHAS level measured.
Yes.
Considering Dr. Ashish, your time limit,
I think, yeah.
we can go to
discuss the
management.
just let's come to the treatment part. How
Treatment
will you
part.
manage this
Yes,
case?
ma'am. And first of all, we would like to manage our case with the lifestyle modifications, which includes weight reduction, exercises. We should advise patient regarding the importance of weight reduction in our case. And we should advise her exercise, which she can do from moderate to vigorous exercises. Moderate exercises, which includes 150 to 300 minutes per week. We can advise her 30 minutes of walk daily. And
Any
if
specific
in case of
exercise types?
adolescent, she can have more than 60 minutes of exercise per day. That can include any aerobic exercises or mass strengthening exercises or bone strengthening exercises can include. And regarding diet, we can advise her to avoid junk food, fatty foods and outside foods. And we can advise her homemade food, healthy, including avoid wheat rotis, and she can have ragi, bajra, jowar, which is common in her home. And to have more high fiber diet, she can have fruits and to have
Exercise is 60 minutes exercise. Where did you find it? Reference?
ASHRAE guidelines.
So for adolescent, it is
It is more than
60
60.
minutes per day plus muscle strengthening exercise that should be done at least 3 days per week.
And what about, like, supposing the patient is your patient is not obese? In that case, would you like to give the exercise routine or not?
Yes, ma'am.
If she's
They have
not
to-
obese also, we should advise her exercises and prevent the
Weight gain to
Prevention of weight gain to
maintain the same
maintain-
weight.
Is it or something else? How else the exercises do help besides reducing the weight?
Metabolism.
For
Ma'am,
for betterment of metabolic complications as well as betterment of insulin
Metabolic
resistance.
complications will come later, something at the moment. What is the basic reason why this is all happening?
insulin
Insulin
resistance to
resistance.
reduce the
Yes, to break the
Yes.
insulin resistance, the exercises are important
have to
even
be
in
done.
cases of the lean PCOS. And
PCOS.
how much weight loss in obese
At
is,
5%.
good enough to give you some
Even 5%
positive.
reduction will help
5
her to
to
resume
10.
her normal menstrual functions.
5 to 10% is ideal.
not ideal, but good enough to
Good
enough
to have
reduce
her
the blood.
normal
It's not
menstrual
the
functions.
ideal.
Because otherwise weight loss tension can be a stress factor which
Yes,
can create
Yes,
more
yes,
problem.
yes, sir. Yes,
So,
sir.
So if
so
she
we
loses
can engage
5 to 10%, you give her a positive that you're going in a right direction, and she'll be, at least you will encourage her for doing
because
that.
they are adolescent. We may engage them in some dance class or the sports
aerobic
like
exercises
swimming, tennis, or badminton in the court, so that automatically
Zumba is very common,
common.
is very much liked by these girls, right? So you
Yes.
can go further. What about the medical treatment if need be? When will you start? Which one will you start? And how for how long?
Ma'am, if she's having features of menstrual irregularities, as she's having in our case, and features of hyperandrogenism, then we can start with her OCPs, which are combined oral
Straight
contraceptive.
away, or once you was telling something, lifestyle and then
Ma'am,
weight
lifestyle
loss?
we
If
will
they are
give her
not,
even after
When
6
will you
months.
start
Ma'am,
the
after 6
treatment?
months of the lifestyle modifications to her, if she's not compliant with that and she's not having her weight reduction, like we will
You have
call
not
every.
mentioned the word counseling, which is the most important thing. 6 months आप wait करा रहे हो, उतने देर में सारी family will be asking you again and again their apprehensions, and the menstrual cycle has not come. So you have the most important thing is counseling about
Counseling.
this also, right? So
Yes,
that
ma'am.
is very important. And I mean, consoling that this process, this is a metabolic problem, hormonal disturbance. It will take little time to get it corrected. So we'll do first lifestyle modification and weight loss. If it is not corrected, then we'll go ahead with the hormonal
Pharmacological.
treatment.
And
Will you
OCP
like to
switch.
give hormonal treatment in this case immediately? Why there is another factor here?
Ma'am, as she's having features of hirsutism, we
What
would
is
like.
her age?
Ma'am, she's 17 years old.
So when can you start?
Ma'am, we should not start OCPs before menarche. And after
Before menarche?
means after she has attained her menarche, within 3 years, we can start her OCPs.
What is the right age to start with it? Why we don't want to start the hormonal treatment
within
earlier?
3 years of the menarche.
Ma'am, because of associated risk of long-term OCPs can be associated with the thromboembolic complications. as
Leave about long
Natural
term, beta.
maturation.
Abhi kya hai? What is the present problem?
And because during this time, she'll be having her normal pubertal changes within first 3
Be
years of menarche.
specific. Don't divert us. Be
Growth,
specific.
growth,
What is
growth.
the problem?
Growth.
It
Height.
is the ossification of long bones.
And we are giving combined OCPs, which is having estrogen, may lead to
You
premature.
give combined or
fusion of
any
bones.
hormone that will affect her diffusion of the long bones.
Long
And
bones.
it will affect her height. So you don't give at least for 3 years. So you have crossed it, okay, but you should know it that one should not jump to the hormones as soon as the person comes for the treatment, because the family is very worried. So therefore I said counseling becomes very important. आपको उन्हें कंसोल करना कि कोई बात नहीं, it will be corrected, otherwise nahi hoga, we'll take care of it. So
So
give
we
them
will
those.
end this with the note that what Dr. Kiran Pandey has said is extremely important. Counseling, including family counseling, because parents are more worried than the little child. And we have to tell them the patience is the key. The most important thing is the patience, and patience pakad ke rakhna bahut difficult job. It is the most difficult job because every month she will come back and she will say, doctor, the weight is not reducing, what to do, etc., etc. She's doing a lot of exercise, etc. So with that note, I think
One just last point, sir, because they
yes.
had mentioned metformin very rapidly, 15 seconds. Why metformin? And in which case you will start, which case you will not start?
Sir, if she's
If
having
we-
signs of insulin resistance, in our case, she's having central obesity.
for
So
obese
we would like
PCOS,
to-
sir.
Always? Or you would look at the fasting insulin glucose ratio?
Sir, we can give without having sir fasting insulin this ratio also, because if she is having signs of these insulin resistance and she is obese, they are not going to relieve by they are going to relieve less by alone OCPs. So we can
Okay.
combine either
Metformin.
metformin with the OCPs, sir.
Okay. So I think
Okay, thank you very much
very much.
for giving us this time. Although thoda long case, according to that case discussion, it was little bit less. Anyway, thanks very much. Dr. Ashish, will you permit me
Yes.
to leave as I have some patient also to be seen?
Okay, Dr. Doshi had to leave because he had one of the staff in labor. And I wished him that I hope that she is not presenting with breach. And you are
Okay.
So you have to excuse
Okay,
you
okay.
also.
By the time
Thank
you may come up with the forceps,
Yeah.
so that if we vertex also, it will be fine.
Right.
Incidentally, let me have a declaration that I have no case waiting at the present moment under my care, especially in the second stage of labor, and that's the patient we are going to address now.
Yeah.
Thank you very much,
Okay.
dear
Thank you.
Thank you
students.
very much, sir.
You have passed very well. You have read the
And
issue
yes,
guidelines.
Dr. Prerna and Dr. Vaishali, well
Vaishali.
done.
Thank you, sir. Thank you, ma'am.
Okay.
You can stop the share screen. Good presentation and good examination, good crossing. Everything is good. And congratulations, Dr. Vandana. Also, you have guided your students very well.
Thank you very much, sir.
For the effort that you have put in for the good cause in ICOG. And I suppose that all the students should go back to the ICOG website and find all these things. You can easily recover these things from the website.
Thank you to you, sir, and Dr. Hafizul for giving us the opportunity.
It was our pleasure.
My students are lucky enough.
Yeah.
Thank you.
Thank
I
you, sir.
wish you
Thank you, sir.
similar luck during the examination. They're in the second year or third year now?
They are the third year, sir.
Third year. Okay. All the best for your exam.
Thank you.
Exam is in
Thank you,
December,
sir.
right?
Yes, sir. Thank
Yes,
you.
sir.
January
Thank
and
you so much. Thank you so much. And we close this session. Hafizul, please.
thank you, Officer, everyone.
Sir, thank you so much.
Dr. Nitin Daitla, I must thank you profusely, along with Dr. Kiran Pandey and my co-examiners. And yes, Dr. Hafizul.
Yes, sir. So we can start the next session, sir.
Yes. Perfect.
So thank you so much to all the faculties, the additional faculties and the students. And thank you, Dr. Vaishali and Dr. Prerna for your nice presentation, as well as Dr. Vandana for having guiding your students, as well as Dr. Savita also. So now we'll have our next session, that is technical demonstration of the forceps. That is very essential, and many times the students would like to know it's from our experts. So today will be demonstrated by Dr. Ashish Mukhopadhyay sir, and sir is everyone knows that he was previously vice president of FOGSI as well as ICOG governing council member, and now sir is actively involved with this program from last 3 years. And he's one of the important pillar, and he's a great academician for this. So over to you, Ashish sir, for the session, sir.
Okay. So it's 1:25 now. I'll start this. And since the time is not very good enough for the entire forceps discussion, I have selected out some of the things that will highlight today for the students' benefit. Okay. So this is the instrument that we are going to talk about. This is called obstetric forceps. There are only two varieties which are presently in use in obstetrics. One is this one, which is called the long curved obstetric forceps with or without axis traction mechanism. And another is the short curved obstetric forceps, or otherwise known as the Wrigley's forceps. And these two we are mainly going to discuss. And particularly if you look at the clinical usage, you will find that in most of the circumstances we're using this one, that is the Wrigley's forceps or outlet forceps. So students need to know very carefully what are the different types or applications of forceps, classification जिसे बोलते हैं, and you must not falter about this forceps in examination.
Ashish sir, 1 minute.
Yes.
Sir, if your camera is little bit up, because it is not entirely visible, the forceps, I think, or you can little bit of or you can be.
Is it okay now?
I think, it's better than before. Yeah, now it's perfect. Yes.
Okay, perfect. So the assisted vaginal delivery, and also called the operative vaginal delivery, is rarely used these days. And I think that there are many students who haven't seen this procedure. And for them, I think it is recommended that they should know the technique, the art of presentation of the forceps, application of the forceps, the pull or the traction, etc. I'm not going to theoretical discussions as to who discovered forceps when and what was the family secret, etc. But the components of the forceps, they should know. First of all, there are two blades of the forceps. It's a paired instrument. So there are two blades of the forceps, and there are each blade, if you consider, then you will find that there are three parts of the forceps. One is the blades, This one is the blade, this part, the fenestrated part. Then the shank is there and the handle is there with a lock. So it's a paired instrument, and obviously it has got sides. Which side? Now, which side is determined by the maternal pelvis side. So left side and the right side. So you need to identify which one is left and which one is right. Now, if you keep the forceps on a flat surface, like take my hand as a flat surface, then you will find that the one end of the forceps is going up. If you keep the forceps like this, it won't be stable. It will fall down. So you have to keep the forceps like this. That means the one end is up. And this end has got two curvatures. One is the cephalic curvature. This is the cephalic curvature where the head is held. This is like this. That's why it is called the cephalic curvature, this curvature. And another is the pelvic curvature. This is the pelvic curvature. So the pelvic curvature is according to the shape of the pelvis or the birth canal, and therefore there are these two curvatures are there. The question is why this fenestration is there. The fenestration is simply there because you need to have a good grip of the head, and also it will lighten the decrease the light of the instrument. It's quite a heavy instrument, you know. It's a quite threatening instrument for the patient. Okay. So now you determine that this side is up. So the head is here. So this is the left blade. You can easily identify this. So if you hold the head like this is the left side of the mother's pelvis, and therefore it's a left blade. And the other blade, that is this one, other blade of the forceps, that is if you keep the head here, and the cephalic curvature looks medially, and therefore it's a right-sided forceps. So there are two sides, left and right, and if you articulate them properly, they will look like this, you know. So the cephalic curvature and the pelvic curvature, they are like this, and they are enclosing the head, and then there is a shank, and then there is a handle. Now, there are some distances or some measurements which are pretty constant in forceps. You cannot increase or decrease them. So you cannot manufacture your own. There are fixed distances. The distance between the widest part, that is very important, and that should be 9 centimeters. This one. The widest part in a forceps blade enclosed is 9 centimeters or 3/3/8 of an inch. If you remember, the biparatal diameter is 9.5 centimeter. So there is a compression of 0.5 centimeter by this forceps. That is one of the functions of the forceps in order to have a good grip. But it is also important to remember that you cannot have this compression more than that. Then it causes more damage to the fetal head, a matter of concern. More importantly, the distance between the tip is 2.5 centimeter or 1 inch roughly. Okay, so that is also constant, because otherwise the compression effect increases. And this shank, this is 2.5 inches long, and the handle, which is 5 centimeter or 2 inches long. So these are the measurements that we have. The shank is incorporated because you need to increase the length of the instrument, and the handle is for a good grip. You have to have spaces for the fingers to keep. This is the areas where the fingers are kept. Okay, so this is the articulated long curved obstetric forceps, which is clinically in use, many of the cases, and also the outlet forceps, which I showed. Now come to the cephalic and after the cephalic and pelvic curvature, the next important point is the function of the shank. I have told you. Advantages of axis traction. Is the axis traction necessary these days? Well, this forceps has got, if you look at closely, you can see a groove here. This is the groove. This is the groove in which the axis traction rods are attached, put here. So axis traction put rod one here and one here. So there are the two places where the axis traction rods will be placed, and then it will be connected to the handle like this. And there will be a connecting device which will enable you to hold the forceps without holding the handle. So you do not need to hold the handle in case you have an axis traction mechanism. This is the slot which the axis traction rods are there. Okay, these are the two slots, this one and this one. Okay. Now, this axis traction mechanism is not always used. We can use this forceps without the axis traction mechanism also. So that is the purpose of the axis traction mechanism. Now, axis traction mechanism also has the advantage that when you pull the forceps, the direction of the pull is automatically according to the curvature of the birth canal. And that is why I don't need to put different directions to the, to the person who is conducting this forceps about the different directions of traction. I will come to that a bit later. Okay. Now come to the, what are the indications and contraindications of forceps? What are the indications of the forceps? Well, broadly, you can classify into maternal indications and fetal indications. Maternal indications are, number one, exhaustion of the mother. When the mother is exhausted and she cannot push it down, and therefore she will be unable to expel the baby by manual method. So maternal exhaustion and an inability to push is the first indication. Then maternal medical indications like a heart failure patient or a potential candidate of a heart failure, heart disease patients, in order to cut short the second stage of labor. Then we have the official indication like prolonged second stage of labor and also evidences of fetal distress, fetal compromise or fetal distress. So these are the indications of the indication of forceps these days. Now, prolonged second stage of labor, I must clarify that how much prolonged is the prolonged. That has been recently modified, and this modification is done by ACOG and the Society for Maternal Fetal Medicine, or SMFM. What they have said, that with the goal to reduce the number of second stage cesarean sections, so they have mentioned that if you allow the second stage of labor 3 hours in a nulliparous woman, primigravida mother, 3 hours, and in a multigravida mother, it is 2 hours. Now, of course, you should add 1 extra hour for the patients under epidural anesthesia. So 3 hours for a primigravida, 2 hours for a multigravida, plus the epidural allowances is the limit of the prolonged second stage of labor these days. Now, what are the maternal medical disorders? Like, for instance, where the Valsalva maneuver is contraindicated, like, for instance, cardiac patient or a neurological disease, also the cystic lung disease or a severe anemia, heart disease, etc., etc. These are the cases where we would like to use the forceps prophylactically. This is called prophylactic application of the forceps, because we know if we can reduce 2 to 3 contractions of the uterus, then the load on the heart is decreased, and thereby it is beneficial for the mother. That is why it is called the prophylactic forceps. Now come to the contraindications. What are the contraindications for the forceps? Now, the first of all, the extreme fetal prematurity. Although we know that the forceps is not contraindicated for the premature babies, they are indicated because they give them a protective cage for the premature head. But extreme degree of prematurity is a relative contraindication for forceps delivery. There are certain fetal demineralizing disease like osteogenesis imperfecta, and in these cases, the application of forceps is not recommended. Or if the fetus has a bleeding diathesis like fetal hemophilia, like neonatal thrombocytopenia, etc., etc. But the more importantly, from the clinical point of view, the contraindication will be an unengaged head. That means the head which is not engaged, you should throw away this instrument. This instrument is of no use. And previously, this type of forceps application was considered a high forceps when the forceps used to be applied in a floating head case, and then we used to pull it down the birth canal, but that is abandoned these days. It's called adventurism these days. Also, if you have unknown fetal position, you don't know the fetal position, you cannot diagnose by PV examination, then forceps is contraindicated, or a brow or a face presentation like malpresentation, or suspected fetal pelvic disproportion. All these cases you should not classify, you should not apply the forceps. Now come to the classification. Classification means the different types of forceps, applications of forceps, which is very important. I'll start with the outlet forceps. So this is the outlet forceps. I'll describe it in a short period of time because the blades are shorter, the shank is shorter, the handle is shorter, and the more importantly, there is no screw or no lock mechanism in the outlet forceps. Why this is so? Because this is basically used as a pickup forceps. That means the outlet forceps is a special type of forceps, application of forceps, when the leading part of the fetal skull has reached the pelvic floor and at or in the perineum. So that means the fetal head is in the perineum. The scalp is visible at the introitus without separating the labia. That means you can easily see the scalp visible in between contractions, and you don't need to separate the labia also, they're showing. So that's a perfect case for an outlet forceps. And also the other things like the sagittal suture of the head must be in the anteroposterior direction like this. So the sagittal suture must be in the anteroposterior directions in the midline, and there is no degree of rotation beyond 45 degree left. Rotation does not exceed 45 degrees. The sagittal suture is an anteroposterior diameter. The head is in the perineum, and the rotation does not exceed 45 degrees. So that is classically the outlet forceps. So outlet forceps is a type of low forceps. I'm coming to the low forceps, but outlet forceps is a specific design now, specific category now, in which there are three criteria. One is that the head is in between the in the perineum. It is showing in between the contractions and don't need to separate the labia for seeing the head. So that is the case for the outlet forceps. That means the head is lying in the perineum and you just pick up the head and assisting the delivery of the head, and by thereby reducing 2 or 3 or 4 contractions of the uterine contraction, and mostly in those cases where you don't need any pressure or any load on the heart of the mother. So then what is low forceps? Low forceps means when the biparatal diameter of the fetal head has crossed the ischial spine. Crossed the ischial spine by 2 centimeter or more. So 2 centimeter or more if the lower pole of the head, fetal skull, leading point of the fetal skull is more than equal to 2 centimeter beyond the ischial spines, but not on the pelvic floor. That means this is the lower pole of the head, which is coming down, and it is above the pelvic floor, but it is more than 2 centimeter below the, at least 2 centimeter or more below the ischial spines. So this is very, very important. Now, one point of concern here is that in cases where there is caput and molding, this lower pole of the head is often deceptive. So you can have problems and difficulties in identifying the lower pole of the head. In those cases, you need to, manipulate the caput subcutaneum and then touch actually the bony head. That's important. So that should be 2 centimeter below the ischial spines. So low forceps has 2 categories also that are based on whether rotation of the head is more or less than 45 degrees from the median sagittal plane. So that means if the rotation is 45 degrees or less, right or left occiput anterior to occiput anterior, or right or left occiput posterior, both these conditions, rotation is 45 degrees or less. While with rotation is greater than 45 degrees. Now come to the controversial problem of the mid forceps. Now mid forceps, what happens? The head is engaged. That means the biparatal diameter has crossed the inlet. That means it is engaged, but it has not crossed the level of the ischial spines. Now has not crossed has got 2 meanings. One, it's at the level of the ischial spine, which we used to call previously high mid forceps, or other variety of mid forceps, which is almost abandoned now. Nobody does that. Another is that the 2 centimeter, less than 2 centimeter beyond the ischial spine. That means the low forceps level is 2 centimeter. Above that is the mid forceps. Mid forceps also is rarely practiced these days. I think 10% or so in clinical practice. And for this, the ideal forceps is this: the long curved obstetric forceps with axis traction mechanism, or even without axis traction mechanism. Now remember, this classification is important because the other instruments like the vacuum extraction, they do not have a separate classification. Only the forceps has a separate classification system. So this mid forceps, high forceps abundant, mid forceps, low forceps, outlet forceps, you must know by heart. So these are the 3 classifications which are typically applied to the forceps only, not to the ventouse or other devices. And also we know that the rotation is possible with the forceps, but the vacuum extractor like the ventouse cannot have the rotational maneuvers. Okay. Now the next question should be what are the prerequisites for the forceps application? Now let us see. Whenever the students are asked in this question in the exam, they always start with the cervix full dilated. But my suggestion will be that you start with this answer that, sir, the presentation and position of the fetus must be suitable one for the forceps application. Because there are only 3 indications where you can apply forceps. One is the vertex, one is the anterior face, and the other is the after coming head of the breech. We'll discuss it separately, each one, but you must start with this answer. That way it becomes more, because when you finish saying that the cervix is fully dilated and fully taken up, and the fetal heart sound is there, membranes are ruptured, etc., and then the examiner asks you, but the fetus is in transverse lie. So how do you apply forceps? So you start your answer by saying that the presentation and position of the fetus must be suitable one for the application of the forceps. What are the cases of concern? Like the big infants. How big is big? Actually, that's a matter of concern, and there is no unanimity, but of course, we have to have some idea. And then the second point of concern in mid forceps particularly is the engagement. As I said, that you cannot apply forceps unless and until the head is engaged. Now look at this point. I said that the lower pole of the head is 2 centimeters below the, or less than 2 centimeters below the ischial spine in case of mid forceps. That means the head is engaged, but it is not low. It's not a low forceps, just above that. This is called mid forceps. Now, how to diagnose whether the head is engaged or not? As I said, in presence of caput and molding, what happens? The proper level of the head cannot be determined properly, because in many of the cases you will find that because of the caput, you will find that the head is lying at the perineum, almost showing at the vulva, but it has not been engaged also. That's possible in cases of severe degree of caput formation. So you have to be very careful about the engagement of the head. If the head is not engaged, take this case for cesarean section immediately. No need to go with this instrument. Now, how to identify that? How to identifying sutures in late labor? I'll come to that a bit later. But before that, you must undiagnose whether the head is engaged or not. For that, what I suggest, if you can negotiate the caput, then and you find that the deep down somewhere there is the fetal scalp, lower pole of the lower point of the head is there, you can see the level. Otherwise, you have to go for, and also even if you find that, it is always wiser to go in the abdominal part and look for any fetal pole which is palpable per abdomen. Remember, any pole palpable per abdomen is a matter of suspicion. Ideally, there should be no pole palpable per abdomen, but if at all, you can allow only one pole palpable per abdomen. That means 1/5 of your finger, 1/5 of your hand. That means the fifth method, abdominal fifth method, comes into play here. Put your hand above the symphysis pubis. Suppose 1/5 of the head is remaining, and the rest of the head is gone inside. That means it's a case of engaged head. So engaged head diagnosis becomes difficult and often requires experience from an experienced person. So no more than 1/5 of the fetal head should be palpable abdominally. That is the clue. And you can always reassess the fetal position in the second stage of labor. Now, I have talked about the fetal size, which is neither too large nor too small. That is also important. How much is large and how much is small. Now, clinical pelvimetry is also important because there are certain features. Nowadays, we do not go for the detailed pelvic assessment. Radiological pelvic assessment is gone now. Only clinical pelvic assessment is there. But in clinical pelvimetry, look for the features which is suggestive of an pelvic contraction. Like, for instance, a flat sacrum. A sacrum which is flat will not allow the movement of the fetal head, obviously, and therefore it is not a good candidate for forceps delivery. A narrow subpubic angle, when the space of Morris is increased, and a narrow distance between the ischial spines. You can always measure the distance between the two ischial spines like this, your 2 fingers, this index finger and the middle finger between the 2 ischial spines. Place it between the 2 ischial spines. And the officially approved minimum distance at this level, which is called the plane of least dimension, that is 10.5 centimeter. If you cannot accommodate these 2 fingers like this, then it's a case of suspicious mid pelvis, and therefore you cannot apply forceps in these cases. So rule out these things first. So unengaged head, rule out first. Assess the pelvis properly. Proper selection of the cases is very, very important, and now, of course, the woman's consent is important. Now, if you're not sure about these things, then you show the case to a senior person who may be more experienced in assessing the pelvis and determining the cases for forceps application. But it is crucial because otherwise there will be some problems, there will be failure, there will be injuries, and then the forceps will be blamed unnecessarily. And therefore, that is the reason why the forceps use is going down day by day. And also the mother's bladder must be empty before it. Okay, so fetal heart sound should be present, the amniotic fluid must be ruptured, and all these conditions must be there before application of the forceps. As I was talking about the maximum weight of the fetus, there is some consensus about the 4,000 gram or 4 kg. But you have to be careful. More important than the absolute weight is the mother's history. If the mother's history has diabetes, if the mother's history has body mass index, or a prior newborn size, which is more than 3.5 kg or 4 kg, be careful and be more careful about the clinical pelvimetry. Also, the patient is severe obesity. And by that, we define nowadays the definition has changed a bit. More than 40 kilogram per square meter. This hasn't changed. Slow progress in the second stage of labor, or a significant caput or molding, as I said before. So all these cases will be necessary to rule out before application of the forceps. Now, if you go by ACOG guidelines, by the way, if you want to go for single guideline about the forceps delivery, the only one college that is good enough is ACOG. Do not need to read many guidelines for that. Okay, so 4 kg, you remember, or 4,000 gram, you remember. So this is called fetal macrosomia. And I have also told you about the high-risk cases where this macrosomia becomes more important, even at lower birth weight. That is where diabetic mothers or a history of similar deliveries in the past, because this macrosomia may cause problems in the form of shoulder dystocia as well. So you need to be very, very careful about planning the delivery. If at all, you can go for the instrumental vaginal delivery. And where is the lower threshold? I mean, how low is the low? Fetal weight. How low is the low? I think there is a much of this thing prohibition or contraindication about ventouse than forceps, because in forceps we do not have a specified lower limit of the birth weight, but in ventouse it is, and we usually do not recommend ventouse in less than 34 weeks of pregnancy. So you remember that in ventouse it is necessary, but forceps it is borderline just. Now, I should talk 2 minutes about this role of ultrasound in the second stage of labor. Extremely important these days. Why this is important? Because the second stage ultrasound is gradually becoming a part of the usual or the normal labor room procedure. Intrapartum sonographic visualization of the fetal intracranial structures, that's important. Like, for instance, the cerebellum, the orbits, and the midline forks. They can determine the fetal position accurately. What we do in clinical pelvimetry or clinical assessment of the head is we see the diameters, we see the positions, occiput, we see the sinciput, we see the biparietal diameter, we see the parietal eminences, etc., etc. But we cannot go into the internal structures, which is possible only by the ultrasound. And so if you can visualize all these organs, intracranial organs, then I think determining fetal head position is more accurate. And that is why it is reflected in the statistics also. Remember, digital examination is incorrect in approximately 20 to 40% of cases. So chance of inaccuracy is there. All these years we have been doing this. And still after this lecture also, many people will do that. Because but remember, the ultrasound inaccuracy is only 1 to 2%. So whatever is good for the patient, you must accept that. And if you're not yet done this, on your exam, you can say that the second stage ultrasound should be a part of the routine labor room care. And also, ultrasound can diagnose lack of engagement in all those borderline areas where it is not possible to find out properly, even doing vaginal examination and abdominal examination, whether the head is engaged or not. Sometimes it becomes very difficult in presence of caput and molding. In those cases, lack of engagement can be correctly diagnosed by the ultrasound. And what do they see? They see the angular progression, they see progression distance, and midline angle measured during pushing had high prognostic accuracy for predicting a complicated or failed assisted vaginal delivery. Now, it is particularly more important during when the cervical dilatation more than equal to 8 centimeter. Last words about a few things about the before I go into the technique of application. Episiotomy. What is the role of episiotomy? ACOG doesn't routinely recommend episiotomy, but we all know that we apply episiotomy, medial lateral one, because we want to be comfortable with the procedure. What type of episiotomy? Medial lateral episiotomy. And usually it is better if you do it after application of the forceps because the skin is stretched. The perineal skin is stretched then, and you can put a good episiotomy. Otherwise, you will have a lot of problems. Now, the most important thing about forceps delivery is when to abandon this instrument that you must know. It is said that the good surgeon is defined by the practice. When does he stop the surgery? And he knows how to stop and when to stop. So that is why whenever you want to stop the procedure, when they abandon the procedure, that you are a good expert. Now, how much is enough? You can call it enough. Usually, there is more or less consensus on the adequate traction after proper application of the forceps. Of course, if you have 3 attempts and then the baby is not moving a bit also, or rather there is no descent, abandon the procedure. That is one rule of thumb. And the second rule of thumb is some people say that 15 to 20 minutes of time or after 3 pulls, whichever is greater, you apply there. Now, what happens in these cases? You forget the instrument, but do you attempt with a different instrument? I think ACOG doesn't recommend that, and we also don't recommend that. Like the forceps has failed, now let us put the ventus, or let us put the other devices. That is not recommended. So go straight away for cesarean section. I think there is no question any shame or inhibition in such cases. Okay, so I think now I will go into the actual technique of application of the forceps. And for that, I need an articulated pelvis. I will put it here, and I'll try to show you how we apply the forceps. Can you come and help me, please? Dr. Mukhopadhyay is helping me. You hold the pelvis like this, and the head like this. To show this. Right. Okay. I will show you the long curved obstetric forceps first, and then the outlet forceps. And you will be able to identify the difference between the two. Can you see Hafizur? Just give me a feedback. The students must be able to see.
Yes, sir, it is visible. But if the camera is a little bit far away, it will be good because
Yes. You want
perfect.
Okay.
Yeah, perfect. Sir. Thank you.
Thank you so much. So we've identified the left blade and the right blade. This is the left blade. This is the left blade which has to go in first. Okay. So left blade needs to go in first. Left blade means maternal side, left side. So now hold the forceps like this at the junction of the shank and the handle in a pen holding fashion. Why pen holding? Because pains can rarely kill a person or a baby. You may hold the forceps like this or like this, but none of them are recommended. So this is the pen holding grip of the forceps, as if abhi gir jayega forceps haath se. So that is the perfect way of holding the forceps at the junction of the shank and the handle. This is your left hand. Because the left blade I'm going to introduce, hold it with your left hand. There is the head in front of you. Put your right hand, 2 fingers, just 2 fingers put inside the vagina by the side of the head. Can you see this? Okay. And then touch the tip of the forceps gently with the tip of the fingers. Cannot see the fingers, right? No, sorry. So touch the tip of the fingers with the blade. Okay. And then gently push the forceps. Try to bring it inwards by the push, gentle push by the thumb like this. Okay. So this is the way forceps goes inside the birth canal. It should be like a hot knife in a cold butter, like this. It should go smoothly. And then assistant holds it like this. Yeah. Okay. Then you take the second blade, that means the right blade. Hold similarly at the junction of the handle and the shank. Okay. And similar, that is pen holding fashion. Take the forceps right blade above the left blade. Put your left hand similarly, likewise, like this, inside the vagina. Inside the vagina. Touch the tip of the forceps blade with the fingers. Scan, bring the forceps downwards and push it gently inside the birth canal. So this is the way the forceps goes inside. And then we just put the lock here. I mean, put the, yes, this is the lock here. And then you are ready for the forceps delivery. So remember, this is the way of correct application of forceps. And you have got enough facilities for keeping your fingers and enough distance of the forceps blade for giving the traction. Now come to the traction. Now this is used for the mid forceps or low mid forceps. In those cases, the traction is different, and outlet forceps, the traction is different. So you must know them, both of them, because the examiner will give you the outlet forceps and ask you the pull of the outlet forceps. Examiner may give you this long cord obstetric forceps and ask about the direction of traction. Direction of traction is extremely important. So the first pull is downwards and backwards. And you put your left hand on your right hand like this. And your finger should be here. So this is the place for keeping your fingers. So with the both hands, give gentle, sustained traction downwards and backwards. This is called downwards and backwards. Why? This is downwards towards me. This is downwards. And towards the floor is the backwards. So the combination, resultant force is downwards and backwards. So this is the downwards and backwards force. Okay. You got it? This is very, very important, downwards and backwards. How long should you continue this downwards and backwards business? Until this area, subocciput, hinges under the symphysis pubis. We all know the mechanism of labor. That day I discussed about the mechanism of labor in cephalic. So till the subocciput hinges under the symphysis pubis. Now what is the idea that you get? You can get some idea about with the hairline, but you can see that there's an area, suddenly the head becomes a bit fixed. It cannot be moved anymore. Then change the traction direction from the downwards and backwards to the horizontally downwards. Horizontal downwards is a peculiar term, but horizontally downwards means directly towards you, like this, like this. So horizontally downwards or directly towards you. This is the second pull. This is very, very important in order to deliver the head. And now the head has started delivering. At this point in time, it is showing in the vulva. It is called crowning. And now you have to give an upward and forward pull. Now here, most of the forceps deliveries I have seen, they cause a lot of mistakes. What is upward and forward? Upward means towards the patient's head, this. And forward is towards the ceiling. You understand this? All the directions are according to the anatomical position of the mother. So upwards and forward, the resultant force is this. Resultant force is this, just like a takeoff of a plane. Now tell me, with the single hand or these two hands, how can you do this upwards and forwards? You can do that, cannot do that. So at this point in time, when you are starting the upward and forward pull, you change your left hand, put your left hand on the shank, put your right hand like this, and then you put the upward and forward like this towards the mother's abdomen. If you do not do that, there will be an increased diameter of the fetal head emerging through the perineum, and they'll cause a lot of tears. So I think today I have clarified about the direction of pull, and particularly this upward and forward movement, many people are not doing properly. So you have to do it like this towards the mother's abdomen. This is called upward and forward. That means it is akin to a flight which is coming down, landing, then going on a runway, and then once again taking off. So that is the direction of the forceps pull. So this is in cases of the long curved obstetric forceps. Now come to the outlet forceps. In outlet forceps, things are not so difficult. You can see that the shank is shorter, the blades are shorter, and when you pull the forceps blade like this, you put it directly horizontally downwards towards you. And then also upwards and forwards. So this every delivery of the head needs upwards and forwards. Why? Because to promote the total flexion of the fetal head, the fetal head should come down like this, and it should be total extension of the fetal head, complete extension of the fetal head. So how do you do that? So first pull is horizontally downwards or towards you, and then you can change your hand position. This is done with a single hand only because it's a pickup forceps. An instrument is also lighter. So you pull it like this. So with a single hand, the outlet forceps or the low forceps is possible, but not that long curved obstetric forceps with axis traction, with or without axis traction mechanism. So remember this. In exam, when you are asked to show the pull, direction of pull, always use both hands in cases of long curved obstetric forceps, and you change your hand from the horizontally downward position, then change your hand, keep your left hand on the shank, keep your right hand on the handle, and then put it like this. This is the only way you can do the upward and forward traction. No other way. With a single hand, you can never do this upward and forward. You can go maximum forward, not upward. You cannot go upward with the help of this hand. Okay, or you have to get up and go to the mother's abdomen. That's not possible. So the suggestion is you put your left hand here, put your right hand here, and then pull it like this. This is like takeoff of a flight. Okay. So that is the difference between the long curved obstetric forceps and the outlet forceps. So now you understand the difference. Today, 90% of the forceps usage is by this instrument, either a low forceps or an outlet forceps. Outlet forceps largely outnumbers the low forceps also. So you should clinically differentiate between the difference between the outlet forceps and the low forceps. And I think my lecture is almost finished. I'll just go through the few obligations of discussing the complications of different forceps applications. All of you know that. I mean, it's not a theoretical discussion, but it is a discussion of practical importance, whether you should learn the proper technique of application of the forceps and the traction of the forceps. I think I'll go through the complication. All of you know the fetal complications, the maternal complications. I will not go for that. There are a few questions which are like why the left blade is put first, and why the right blade is put, where are the cases where the right blade is put first, etc., etc. What are the fetal complications? Most important is facial palsy, which is very common, quite common, but it is reversible, so no need to panic. There is no need to do some heroics. Only thing is that the mother may be panicked. Mother is very, very worried about seeing the baby, but assure her that she'll be all right. Then there's a cephal hematoma, bruises and abrasion, which are quite common, but uncommon, but they also need to be observed. Then the ideal actual complication of forceps delivery, which was initially much discussed, was the asphyxia and intracranial injury. Cerebral palsy is rare, but these asphyxia and intracranial injury, these two complications are most lethal complications, like also in breech delivery. So now come to the last point, that is the failed forceps. What is a failed forceps? Failed forceps means either there is a failure of application, a failure of proper identification of the case. I mean, you haven't screened your case properly, like all the screening points that I have discussed before, that whether which cases you have to apply the forceps. Remember, you have to safely deliver the baby without causing a lot of injuries or damage to the mother and the fetus. So causes of failed forceps will be, the most important cause, the most common cause is the undiagnosed occipital posterior. And here is a point of concern that the occipital posterior is not very easy to diagnose, but you have to diagnose the many features. Like for instance, this abdominal flatness, suprapubic flatness, the altered location of the fetal heart sound, starting from there, and then you come down, you cannot find out the sutures, and that is because there is cap pattern molding, etc. You cannot find the sutures, so you go by the fetal ears. Somehow you have to diagnose where the occiput is. If that is not possible, ultrasound can help you. So in-labor ultrasound and second stage ultrasound is of immense value these days. There are other malpresentations also where like brow or mentoposterior face, mentoanterior face is possible, just like a vertex, but mentoposterior face is a contraindication and the reason of failed forceps undiagnosed. Then there is incomplete dilatation of the cervix. There is some cervical lip which is remaining there, or there is some undiagnosed cephalopetal disproportion couldn't diagnose properly, or there is some constriction ring rarely, or the fetal malformation like the thoracopagus, pyopagus, etc., undiagnosed hydrocephalus, etc., etc. I think I will close it here. Application of forceps in occipital posterior, the direction of pull is a bit different because you need to deliver the head by a different mechanism. So that is quite conceivable by the students, I think. And Piper's forceps, I think Dr. Harish Doshi has mentioned about the Piper's forceps. We do not have Piper's forceps, but we can do the service with the long curved obstetric forceps with or without axis traction mechanism. So I think I have finished everything, and it is more or less a practical discussion rather than a theoretical discussion. So I believe that the students, if they have any question, they can ask. Thank you very much. I have finished it in time, maybe.
Excellent talk, sir. Most practical tips and most useful aspects, day-to-day parts, which PG needs to know. Thank you very much, sir.
Thank you, Dr. Nitin. Thank you so much. Okay.
Thank you, sir.
Students, do you have any questions? Then you can ask. No questions. Sir, I can't hear you. Is it Dr. Hafizu speaking? Can't hear you. May I know who's speaking?
Okay, so by the time, if somebody send a question in chat box, will be easier. So put your question in the chat box, so the audio problem can be taken care of. By the time, sir, you can answer that part of why left blade first, sir.
Yes.
Some common queries.
Yeah, left blade is put first because the lock is placed in such a way. I'll show you this lock. Yes. Lock or the mechanism of putting this thing is such that the lock looks upwards. Can you see this? With this forceps blade, which is looking upwards, this is the right direction of the blade. And then if you put the right blade first, then there is difficulty of putting the left blade from below because the lock is like this. So that's the reason why the left blade is put first. And the direction of pull is slightly different in cases of face to pelvis delivery or occipital posterior. I haven't discussed them. I have just kept the discussion simple in order for the PGs to comprehend this. Okay, I think the screen is absolutely silent. Nobody is there. Everybody is left in the right direction. Dr. Hafizur?
I think in chat box also there are no questions.
No questions, yes.
It was an excellent demonstration, and that was the purpose of having this class. I think we have done justice to it, and I am sure the students will be lots of beneficial from all the technical, because this is very much lessly done for the spam. Many times we have only the PPT and all this, so it was really nice to see you showing all the nitty and gritty. Good thing is that it will be in the ICOG website in the recorded link, so students those who have missed it can go through this later on also. We'll upload it. So thank you so much, Ashish sir. And I would like to thank you all our faculties, Harish Doshi sir, then Ashish sir, then Dr. Nitin, Dr. Ajit, and the Kiran Pandey madam for having everyone, and all the students, Dr. Vaishali and Dr. Prerna, and Dr. Bandana for having the students. As I told, we will have feedback from the students after this session. Ashish sir, I think we can have a little bit of later on with the form from them. What they want also now we can ask.
Correct.
Over to you, Ashish sir. Maybe you can conclude.
So Prerna and Vaishali, do you have any suggestions about today's program? How good or bad, how beneficial it was for you for the exam purpose? You are going to appear at the exam very soon.
Yes, sir. For us, it was beneficial as we could prepare one entire long case for our exams and we could know the questions, how the questions will be there.
For Viva
and
also, sir.
For Viva also, and regarding the recent guidelines also, we could read. So
Yeah.
it's very beneficial for us.
I think it is very good to read the recent guidelines, but remember all they are borrowed guidelines from another country across the Atlantic. Therefore, I would rather suggest that whatever you have learned in the last 3 years of your life, you must not forget that.
Yes, sir.
Whenever you talk about any guidelines, if it is theory or in principle, it's okay. You can always quote the guideline. For instance, the adolescent PCOS definition, the vast changes that they have taken, like the PCOS definition or 2018 modifications. You cannot do anything about them. They are in place. They are in place and they are being applied all over the country, all over the world. But the practices that you do, like for instance, which kind of heparin do we use in your clinical practice? Low molecular heparin or non-fractional heparin. You must stick to your usage because you have learned something painstakingly over the last 3 years. And you must say that, yes, sir, I have learned, we have learned it this way. We do this in these cases. There is no problem about telling or describing about your usage in clinical practice, because for the instruments available, techniques available, or the methods available, or SOPs available in your hospital, you are not responsible for them. You are just a part of the system. So on the other hand, think about this. If you go on saying the theoretical things, then the examiner might have the impression that you need to do them once also. So with those notes, I hope that's not the case with you. And I hope that this is not the case with any student in our country. Thank you very much. And this is my privilege to close this session.
Thank you, sir.
With a lot of
Thank you, sir.
regard to all the professors, all the teachers, and all my dear students. Thank you very much.
Thank you, sir.
Thank you,
Thank you
Afizul,
so
and
much.
entire tech support team for helping this event to happen.
Thank you, Dr. Nitin. You have been
Thank you, sir.
exceptional.
Thank you so much. I think technical team can stop recording. Thank you so much. Thank you, everyone. I think we